Thank you, Honourable Chairperson, for this opportunity and for opening the proceedings. My name is Jacques Duprier, and I'm representing the F.W. de Klerk Foundation in these proceedings today. And before I start with the more formal presentation and our submission in this regard, allow me to express my gratitude on behalf of the F.W. de Klerk Foundation for this opportunity to address you, Chairperson, and also the other honourable members of this committee. Thank you to Ms. Majalamba for logistical and technical assistance to allow us to do so. And from the foundation side, we most sincerely hope that our submission is positively received, and most certainly us engaging with the committee on this most important aspect for all South Africans, that we find each other on favourable terms, and that our submissions be viewed not in a way as critique or in a non-positive way, but indeed in an engaging, positive and constructive way. Because like the members, I think like everyone here, and like you, Chairperson, like the other honourable members at the Foundation, we share the concern on this most important topic of national health insurance, and also the provision of health services and healthcare to all South Africans, and then also the idea and the concept of universal health coverage. So again, just to cap off my introduction, thank you for this opportunity. We are grateful for it, and we hope to constructively engage with everyone in this regard. The F.W. de Klerk Foundation, Honourable Chair, is a not-for-profit organisation, and we work to promote and safeguard South Africa's Constitution and its Bill of Rights. And then we also work as a team and as a non-profit with this overarching goal towards promoting positive relations and community building efforts in South Africa and in its various communities. Chairperson, allow me to just share my screen, honourable members. I'm just going to share my screen with you to indicate and to bring our submission in that regard to the fore, so that as I proceed with our submissions, that I can indicate and take you with me through various aspects that we feel would be important to bring into your attention. I think I would like to start off right at the beginning, perhaps by way of lighter introduction. I'm by certain no means an economist, and I'm by certain no means a health practitioner, as so many of our colleagues here. I'm a mere low legal practitioner and a lawyer. So within this framework, allow me to engage with you, Chairperson, honourable members, on our views and the Foundation's views on a number of crucial aspects and a number of key concepts in the bill. And if you will allow me, and I apologize, I'm just scrolling through the document here to just, for ease of reference, make it easier for everyone. I would like to take you to page 16, to those honourable members that perhaps have the document open before them already. And here, I would like to first indicate the Foundation today would like to address, and we also compiled a submission in this regard, and we would like to engage on this issue broadly in terms of three overarching themes. The first overarching theme, and before I take you to specific paragraphs and specific core concerns we have, and I will get to these in turn, the first one is the Foundation would like to make certain submissions and have made certain written submissions on the bill as it stands regarding the rule of law and the need for legislative clarity, as in our view, there are a certain number of components and a certain number of key aspects in the bill which are vague, and we submit so respectfully. And this vagueness or this legal uncertainty, in our opinion and respectfully, will need to be cleared up to satisfy the concept of rule of law. So that's the first broad and overarching theme in terms of which we've delivered submissions. Chairperson, the second one, the second overarching theme, which I will get to, is basically, and in essence, governance concerns, where I will refer you, Chairperson and honourable members, to what we view from the Foundation as a fairly wide and an unfettered power and discretion that is allocated to the Minister of Health in terms of the bill, and we've raised certain concerns in this regard. And then, very important for us as a foundation, and where I would like to start my engagement with you today, is the impact of the National Health Insurance Bill, or the NHI Bill, on the South African Bill of Rights and the Constitution, and a number of constitutional concerns in this regard. That's why I referred you, and if I may do so respectfully, to, I beg your pardon, if you will bear with me, page 14 of our submission, which is on the screen, and not page 16. And here, the first one, I would like to just very quickly, before I move on, address you on the potential impact on an individual's, or rather, let me start by saying this. In our view, there are a number of provisions in the bill, in the NHI Bill, which will have an impact on a number of rights in the Bill of Rights. These specifically, and I will delve into them in detail. The first one is the right to freedom of association, or Section 18 of the Bill of Rights. The second one is Section 22, the freedom of trade, occupation, and profession. And then thirdly, Section 27, which does, or which entitles everyone the right to access healthcare. And here I will get to the word everyone. Firstly, if I can refer your attention to paragraph 2.5.1.1, and this relates to clause 33 of the bill, which provides that medical schemes will be restricted to provide complementary cover to services not reimbursable by the fund. Building on this, I would like to refer you to paragraph 2.5.1.4, just down, which basically extrapolates on the previous paragraph. And we make the submission that clause 33 of the bill brings into question the potential infringement on the right of a person's freedom of association as guaranteed in Section 18. And how do we proceed with this? Paragraph 2.5.1.6. It relates further to the choice of healthcare services and where and how to access these services. And this is interrelated with another constitutional right we respectfully submit, and this is from Section 12(2)(b) of the Constitution, the right to bodily and psychological integrity. And this flows over into paragraph 2.5.1.7, Honourable Chair and Honourable Members, where we make the submission respectfully that the state, and if the NHI Bill is pushed through in its current form, potentially forces mandatory registration of medical scheme users or people to become users of the National Health Insurance Fund, as their medical schemes are denied from providing coverage for these healthcare services. And this then potentially infringes on Section 12(2) of the Constitution as well. And then we make the submission, and this ties into the first broader theme that I extrapolated on, and that's the issue of vagueness, and where the NHI will have to provide in a certain number of core aspects more detailed information. Here we make the submission, one would need to determine whether the means adopted to achieve universal health coverage, to give effect to Section 27 of the Constitution, justify limitation of this right or these rights to freedom of association and the right to bodily integrity, and whether this is justified in terms of the Constitution. So we make the submission to just tie this specific submission, to tie this off. We make the submission that in our view, there is the potential risk that the NHI Bill as it currently stands can infringe on freedom of association, I beg your pardon, on the Section 18 right, freedom of association, and this is interrelated to Section 12(2), the right to bodily and psychological integrity. To move on, we also believe respectfully that in terms of Section 22, the National Health Insurance Bill, or the NHI Bill, may impact on the freedom of trade, occupation, and profession of health service providers. And here perhaps I can just indicate to go over to page 17, I beg your pardon, page 16, and whether this would be justified. I would like to perhaps just by way of of clarity indicate to a most interesting judgment from Canada, and this is law that the committee and ultimately that the legislature can consider in terms of Section 39 of the Bill of Rights, where the Supreme Court in Quebec, in Canada, found that provincial legislation in that country, which prohibited residents from taking out insurance to obtain private sector healthcare services, which was already available under Quebec's public healthcare plan, similarly to what is envisaged by the NHI, was an undue limitation of the rights to life and personal inviolability protected in terms of Canadian law, more specifically their Charter of Human Rights and Freedoms. And basically, a key aspect of that judgment was based on the unreasonable waiting time for certain surgical procedures under the public healthcare plan, which made this limitation of private healthcare for those processes and procedures unreasonable. I would then like to move on more specifically, and here going over Honourable Chair and members to page 17 and leading off from paragraph 2.5.2.2, Section 22 of the Constitution, providing that every citizen has the right to choose their trade, occupation, or profession freely, and this practice of a trade, occupation, or profession may be regulated by law. I'm not going to go into this too deep by virtue of time or for reason of time to get to a number of other submissions. We can only, and perhaps I should just make the submission outright, that we feel from the foundation side that the NHI bill, if it is proceeded with in its current form, will have an adverse effect on Section 22, the right to freedom of trade, occupation, and profession. And here I can perhaps just indicate paragraph 2.5.2.7. The question is whether the above provisions of the NHI would mean that, for example, a general healthcare practitioner, for instance, could be compelled to provide his or her services at a fixed NHI predetermined rate, regardless of where he or she practices, and whether such a restriction of that profession would satisfy the rationality test laid down in terms of Section 36 of our Constitution when determining the limitation of this right. I would then just like to move on to Honourable Members, paragraph 2.5.3, and this is on page 18, the potential impact of the bill on asylum seekers' right to access healthcare services. And here I can perhaps make the submission respectfully that it's not just about asylum seekers, it is about other people in South Africa as well, for whatever reason that may be, because as we know, Section 27 of the Bill of Rights basically indicates that everyone has the right to have access. So it uses the word everyone. And we feel that this perhaps can be described as a regression from the previous NHI bill. This regression could be viewed as unjustifiable, and as in an unjustifiable manner limiting the rights of other people, in other words, people who are not necessarily citizens of South Africa, to various medical procedures set out or that will be set out in terms of the NHI. And we end off there in paragraph 2.5.3.1. There has been no justification provided for this regression in access to healthcare, specifically in this case for asylum seekers. So, Chairperson, then just before I move on, just to recap on this specific aspect, we feel that these rights that I've extrapolated on, we feel that there is the real risk that the NHI in its current form may impact, for the reasons that I've elucidated already, negatively and in an unjustifiable way on these rights as enunciated in the Bill of Rights. And we feel these are areas of concern, and we felt the need from our side to raise this with you and with the committee members. I think then for me perhaps to move on, and if you will bear with me for moving around in the document, if I can respectfully refer you to page 9 of the submission, and I'll just put that up on the screen, if you will bear with me, and I thank you for that. And here, Honourable Chair, Honourable Members, I would like to focus your attention on paragraph 2.4 and then moving onwards in the document from paragraph 2.4, where it is our respectful submission that the NHI bill as it currently stands really provides a broad net and an unjustifiably broad net of power, and indeed unfettered power, which is not adequately addressed by proper checks and balances to the Minister of Health in then eventually enforcing and enacting the provisions of the NHI bill as it currently stands. If I could take you to paragraph 2.4.5 on page 10, if you will bear with me. Why do we say this? Why do we raise this specifically? Honourable Chair, honourable members, specifically we do so because of the current state of a number of state-owned enterprises in South Africa. I am not going to go into this too much in detail. I think safe to say that most South Africans know that most of South Africa's state-owned enterprises are in a state of disarray, where often corruption, mismanagement, and cadre deployment and cadre employment are key drivers really to the failure of a number of these state-owned enterprises. This is a big concern currently, and we elucidate on this paragraph 2.4.6, State of Nation Address from 2019. And I quote where the President said, "We are committed to building an ethical state in which there is no place for corruption, patronage, rent-seeking, and plundering of public money." And then I can focus your attention on paragraph 2.4.6.1, which goes to the essence of our submission, or this current submission, of why we are saying the Minister will be receiving, in our view, respectfully, unfettered power to make the NHI his or her domain. And in terms of clause 9 of the bill, and I'm just reading here from paragraph 2.461, in terms of clause 9 of the bill, the NHI fund is established as an SOE, and then basically, and I quote, as an autonomous public entity in terms of Schedule 3A of the Public Finance Management Act, and the board of the NHI fund in terms of clause 12 is accountable only to the Minister. And here, Honourable Chair, honourable members, we make the submission as well. This is a regression in oversight over the functions of the board of the NHI fund. In the draft version of the NHI bill published by the Minister on the 21st of June 2018, the NHI fund board was described as an independent board, and it was explicitly stated that the board was accountable to Parliament and not to the Minister. And we feel that no justification has been provided for this severe regression in oversight. And clearly one can see on this new wording, where first the board was independent or cited as to be an independent board accountable to Parliament, it is now accountable to the Minister. There is a strong centralization of power and accountability only to and only in the Minister of Health. If you will bear with me, the submissions we then make further, honourable members, honourable Chair, from paragraph 2.4.6.2 onwards, is basically setting out the various provisions and the extensive powers that the Minister alone will hold in relation to the functioning and the complete functioning of the NHI fund. And here, and I'm not going to go through all of this, if I can perhaps focus your attention on page 11 onwards, where we make it clear in paragraph 2.4.6.8. It's not clear in terms of specific clauses, in this case 13.3 of the NHI bill, who will decide on shortlisted candidates who will be interviewed as part of the ad hoc advisory panel. It goes on in the next paragraph, qualification requirements for the board members of the NHI fund will also need to be strengthened to provide stricter criteria to prevent specifically, and I've mentioned the state of our SOEs, and here we tie it into specifically prevent political interference in the managing of the NHI fund. And we make the submission respectfully that these criteria need to be more objectively determinable. We also extrapolate in paragraph 2.4.6.10 on the requirements of a fit and proper person in terms of its applicability of the NHI bill. We go further and we extrapolate to the requirements that board members should have appropriate technical expertise, skills, knowledge, and experience. And basically, I think what is important, Honourable Chair, is what we make mention of in paragraph 2.4.6.13. The further centralization of power in the hands of the Minister is seen with the appointment of the Chief Executive Officer of the board of the NHI fund in terms of clause 19, this will also be done by the minister. And then also these further advisory committees, as we've indicated, such as the Benefits Advisory Committee, Healthcare Benefits Pricing Committee, the Stakeholder Advisor Committee, and the appointment of members of the Appeal Tribunal. We then just explain our submission in this regard in paragraph 24614, critical roles that these advisory panels play, Honourable Chair, Honourable Members, determining the scope of healthcare, the service benefits to be provided, as well as the price of these healthcare service benefits. So it is crucial, in our view, and respectfully, that all of these people and all of these persons are free from any political interference, and then also that there's adequate oversight mechanisms and proper checks and balances in place to make provision for and guard against any such undue influence and interference. So I think perhaps to tie off this broader theme, an overarching theme, which is the second one that the foundation is concerned about, is we are concerned, Honourable Chair, about what we view as the free range that the minister will have in terms of the current NHI bill, and we feel that there should be more appropriate checks and balances, and that this power should not be as centralized as it is currently worded in the bill. If I can then take, Honourable Chair and Honourable Members, all of us to the Foundation's third overarching theme and overarching concern, and this is the need for rule of law, and as part of this, the need for legislative clarity, and in our view, a number of aspects that as it stand and as they stand in the bill currently are vague and will need to be extrapolated on and be made more clear if the bill is to pass muster in this regard. And here, if you will bear with me, I would like to refer you to earlier in the document, paragraph 2.1.5, if I can take you there. And in the spirit of time, I will refer you to specific paragraphs, and then if it needs be, we can extrapolate on that. I've already touched on, if I could refer your attention respectfully to paragraph 2.1.6 at the bottom of the page. A vague aspect of the bill is the role of medical schemes and to what extent a person currently a member of a scheme will still be covered for healthcare services or benefits he or she currently enjoys. And this is then in terms of what we've referred to already, clause 33 of the bill. In terms of this clause, medical schemes will only be able to offer complementary cover with no information on what this would entail. No information is currently available on the types of healthcare service benefits to be provided by the National Health Insurance Fund. And we also feel, Honourable Chair, that it's unclear whether a person will therefore be obliged to register as a user with the fund to receive the healthcare services that the person's medical scheme is prohibited from covering. And we've already indicated how this could potentially infringe on a number of constitutional rights. We also make mention in paragraph 217, the various proposals as to the income of the fund and the income sources, and most specifically here, reallocating funding for medical scheme tax credits paid to medical schemes to the NHI. And we feel that there's not enough clarity on what the impact and what the real impact will be of this on current medical scheme members. And we feel this is an area that needs to be clarified, considering the immense fiscal impact thereof. And we also make mention of certain statistics that South Africans in 2018, where there were already 9.4 million individuals covered by medical schemes. So it's an immense number of people, and the fiscal implications of this need to be considered. We also feel, paragraph 2.1.8, that the role of the District Health Management Office, the DHM offices as they're referred to, established in terms of clause 36 of the bill, will need to be clarified. And why we say this is to consider it's a health service in terms of Schedule 4A of the Constitution, and this is a functional area where both national and provincial legislatures have concurrent legislative competence. Perhaps for the sake of time, because I would like to wrap up with a certain enough recommendations, Honourable Chair, I would like to make it very clear, and if you'll bear with me, I'll just scroll through the document. We feel that a number of critical measures and critical information have been left out of the bill, and these pieces of relevant information will be crucial to properly inform South Africans of the NHI and what the possible effects of the NHI ultimately will be. And here, if you will bear with me, we make specific reference in the submission, if you will just bear with me, to the Davis Tax Commission and the findings of the Davis Tax Commission. And this specifically ties into what we have explained here in paragraph 2.3.1.5, which stipulates financial implications for the state, and where it touches on an actuarial costing model, which basically brings us down, and it mentions the figure of 30 billion per annum. And we feel, if I can focus your attention on 2316 and paragraph 2317, that this actuarial costing model should have been included in the text of the bill, or it should have been made publicly available, especially if it was commissioned by the Treasury. We feel this is necessary so as to better inform all South Africans, but also the health industry, of the numbers and the costs that we are looking at. And specifically then, for the feasibility of the NHI, we feel that the findings, and as elucidated here in paragraph 2319, the findings of the Davis Tax Committee report should be considered and ought to be either included in the bill, or at least the findings of the bill. It should be extrapolated on in the NHI bill as to how these findings were incorporated and considered in the bill, specifically regarding the findings it made as to South Africa's financial growth, and the figures as indicated here in 23111. Should the real annual growth rate reach just 2%, then the shortfall could be as large as 108 billion. Should the average growth rate dip below 2%, as is currently the case, then it is likely that even the 108 billion rand figure could substantially understate the actual shortfall for the NHI. So we feel a lot of findings such as these, the Davis Tax Commission, and if you'll bear with me with scrolling down, we also feel, if I could focus your attention on paragraph 2.3.2, just before I start ending off, that the bill currently, as it's written, has a strong lack of information on the success or otherwise, or at least concrete and accurate data on the NHI's pilot projects. And we feel that if there's to be a proper public participatory process, this should be more clearly indicated and included in the bill or otherwise. Moving away from our core submission as it is on the screen, I would like to make a couple of general concluding recommendations before I end off my session. Clause 33 of the bill regarding complementary cover needs to be clarified. Healthcare service benefits in terms of the bill needs to be clarified, and not in terms of regulations as envisaged later or at a later stage in terms of clause 55(1)(x) of the bill. The funding aspects as described need to be clarified, and as we've put out in our submission, we feel that the role of the District Health Management Office in terms of clause 36 of the bill need to be clarified. The recommendations of the Davis Tax Committee ought to be more properly considered, and it must be accounted in the bill as to how this was done. We feel that it must be indicated in the bill, or there must be proper consultation on this as to what possible financial implications or trade-offs the NHI will have possibly with other NDP programs, considering the large fiscal implications of the anticipated NHI. As I've stated, more data needs to be included as to the effects and possible results of the NHI's pilot projects and what those were. And we feel that there is really a need for more consultation, and specifically a kind of consultative forum that could implement the suggestions we indicated in paragraph 2.5.2.10 of our submission, and basically working towards an acceptable national pricing regime that will be used for purposes of the NHI. We also feel that the Office of the Health Standards Compliance as an independent body in terms of the National Health Amendment Act should be strengthened, and this could also work in conjunction with strengthening the Health Ombudsman as well as reaching out to the public protector and in a combined way, strengthen existing oversight, accountability, and infrastructure mechanisms. I thank you for your time.
Thank you very much. Your document was actually pointing to where we need to look at. I hope members were not disadvantaged by you having to focus here and there, but you could follow very well what the member was actually saying.
Thank you, Chairperson.
I could pick up that there were certain things we were raising, a mandatory prepayment. But something caught my attention as we were presenting, that there must be a freedom of trade, profession, and all that. Now, I hope we are not suggesting, which is currently the phase, that you should, in the country, not know what is the price of bread. When you get to Limpopo, the price of bread is different than when you go to Gauteng and when you get to KwaZulu-Natal. Why should GPs not be kept as to what is the fixed consultation fee that the GP should charge? Or why should we leave it free for all? Because you then say it is good and it's fine that currently you don't know the price of the consultation. The doctor should charge as they wish. And that is actually expressing freedom of trade and freedom of profession. I don't know, maybe we'll comment on that when we are actually making overall comments, having got all the other members to ask their questions. The following members have indicated, and I've noted them, that they would like to engage with the presentation. The first one is Honorable Kela. Second one, Honorable Dr. Harvard. The third one, Honorable Dr. Jacobs. The fourth one is Honorable Mahlengwa. That was the last time I looked at our chat group. Those are the four that came through.
Honorable Chair,
there are any
Honorable Ismail, please.
Hold on. If there are any other additional members, I now give them the slot to then indicate their names now.
Honorable Munyai.
Honorable number 5 will be Honorable Ismail.
Honorable Sokacha.
Number 6 will be Honorable Munyai. Number 7, Honorable Sokacha.
I also raised my hand, Chairperson. Please note me.
Honorable Chira, you are number 8. Okay.
Honorable Chairperson, if I may interject here, I must indicate right now when you have made mention of all these honorable members looking to ask me questions, I am most certainly going to be in need of healthcare if I listen to the number of questions that are coming. So if you can take that into consideration, I will be most grateful.
Yeah, you are very brave. You told us as you come through that you are a lawyer, so you probably handled that. Oh, just you're reminding me, because this document is a product of the Department of Health nationally, we asked them if this has gone through some legal scrutiny, but not only did we leave that at that, we asked for a state law advisor to come and share with us the views of the legal people with regards to this bill. So I'm sure it is like all profession, there's a different view from whoever is there's a difference of opinion on professionals, on issues that are coming through. But no, we don't be threatened. The honorable members will be asking you clarity-seeking questions. Let me then repeat, and members will come one after the other. First one, Honorable Kela. Number 2, Honorable Dr. Harvard. 3, Honorable Dr. Jacobs. Number 4, Honorable Mahlengwa. Number 5, Honorable Ismail. Number 6, Honorable Munyai. And number 7, Honorable Sokacha. Last indicated was Honorable Chirwa. Any other one that I've left out? Okay, honorable members, let us follow one after the other in that order. Thank you.
Thank you, Dinangwe. Good morning. I've got a question that I want to raise, but firstly, let me welcome the presentation, Chairperson, from the Clerk Foundation. My question, in some aspect of the presentation, the Clerk Foundation appears to be more interested in what will happen to private sector, insured patients, and how they will be impacted on by provision contained in the NHI bill. We already know that whilst medical scheme members are medically insured, they do experience financial challenges under the current financial medical aid system, which the foundation seems to believe is suitable. My question is, should we continue with the current system despite these challenges? And what are the foundation's proposals with regard to how we remade the situation, especially given that most of the intervention proposed in the bill are not acceptable to the foundation? That will be my first question. My second question, would you say that not everyone has the right to choose under the current two-tier system of healthcare? Do only the wealthy have the right to choose? My last question, do you think that Chapter 5 in the Constitutions should be amended to reduce the powers of minister? Thank you, Chair.
Thank you, Honorable Chair, and also presenter. I just have one question. Your foundation has stated that an political approach should be adopted to address health inequalities in South Africa. This statement appears to insinuate that NHI policies are advancing political interest. Can I get some clarity regarding this statement? And in particular, whose political interests are being referred to in this statement? Thank you.
Thank you. Good morning, Chair. Good morning, everyone. Thank you very much for the presentation. I know that you make a reference to the Genesis report in your presentation, and the impression that I am getting is that until there are satisfactory results on the impact of the NHI pilot interventions, you're suggesting that government should not pursue measures aimed at ensuring equitable access to quality healthcare services for South African citizens. And I'd like to get your view on that position. And you also make state as a requirement that there should be consultation to ensure input is noted. Now, the process for developing the bill started in 2009 with the green paper and the white paper on NHI, and later the bill for 6 months, and is still being consulted through the process that is now currently before us at Parliament. Is there any policy and that you think should have been more consultation should have been made? Or do you think that the policies and the bill that we've done so far, or that government has done so far, is adequate? And then very lastly, again, about the pilot projects. You know, your request seems to be very unusual, that inclusions, that the pilot project should be included in the bill. And the question is, of course, when legislation is drafted, whether this is how it is actually done. Now, lastly, it is interesting that you quote the Constitution on many occasions, and you don't really quote Section 27 of the same Constitution. Do you think that the rights of those who cannot support themselves are disregarded as subsections 27? As subsections 27, 1A and C are saying? And what do you think of those rights of those people? I think I'm going to ask you a very last question. Now, we've heard critics of the NHI, such as yourself, saying that there's no money to implement the program, asking where would the money be coming from. And in one of your statements, you cited what happened in Canada, in the same breath of citing examples in other countries to justify this objection of the NHI. What is your comment about the British government implementing the NHS immediately after the Second World War, where there were no resources at all, including the money that the critics are talking about on the NHI? Do you think that the British were in fact in a worse situation than our current situation? Thank you very much.
Mama Sengwa. Okay, Mama Sengwa, are you coming through? Honorable Ismail, do continue. We'll come back and check if Mama Sengwa is able to connect.
Thank you, Chair. Good morning to everybody. And I want to thank you for the presentation. I have a number of questions for clarity seeking. My first question, in your opinion, how well does the bill protect the fund against corruption, theft, or maladministration? Do you think processes have been adequately put in place to check corruption? If not, what more recommendations would you rather be that it should be stipulated so that these can be checked? Second question, you highlight the amount of power the minister has as stipulated in the bill. Would you then recommend a public parliamentary process for appointing the board? What do you foresee the risks of the current method of appointment of the board in the bill? My third question, you mentioned pilot projects and clarifies of outcomes of these pilot projects, which is obviously a concern. But would you also recommend that the department does a pilot study to test legal and operational feasibility? How important do you feel a pilot study is for the success of a project? And is it something that can be bypassed? My fourth question, would you support the NHI in its present form without any additions or, edits to the NHI as we speak? My fifth question, what is your view on the impacts of a single purchaser model? Now, you mentioned that the funding model is unclear, and therefore, obviously, the sustainability of the NHI is unclear and a question mark. Now, assuming there is not enough funding in a few years into the implementation of the NHI, how do you think this will impact the access to quality healthcare or even the economy in the long run? And my last question, you mentioned the OHSC and Ombudsman must be strengthened. Now, currently, the OHSC is unable to monitor even 20% of our healthcare facilities. Government currently evaluates and monitors only 7% of all healthcare facilities. Would you then suggest or recommend that these be strengthened first before the implementation of the NHI? Thank you, Chair.
Thank you, Honorable Chair. My first question to the de Klerk Foundation will be as follows. The FW de Klerk Foundation makes reference to a number of rights outlined in the Constitution of the Republic. However, the argument they put forward by the FW de Klerk Foundation, seems to imply that these rights are absolute and cannot be fitted within the interests of the greater good of society. Can the presenter please clarify this, because NHI is intended to benefit the entire population by reconfiguring the structure of the healthcare system of South Africa. So where in the NHI bill, where is it in the NHI bill? Is it stated that the citizens' right to choose their trade, occupation, and profession? Where in the bill? I'm sure the presenter must clarify. Section 22 of the Constitution, is it prohibited? May he please clarify further? I get a sense that the de Klerk Foundation believes that health-related matters should be delegated to Parliament instead of making Minister of Health a custodian that provides oversight to healthcare matters on behalf of Parliament. I must get more clarities because this structure is the outcome of the constitutional arrangement. It's an outcome of the democratic order and the constitution he deems to respect so much, if I can be clarified. The de Klerk Foundation appears to be against the use of referral system as proposed by Section 7, subsection 2D, and Section 8 and subsection 2 in the bill. The health market inquiry has found that high costs of healthcare are as of a result of supplier-induced over-servicing, where the condition that could have easily been treated at a lower level of care gets escalated to a higher specialist or tertiary level. Should that not be therefore be compelling reason to put place a mechanism that mitigate this problem? Furthermore, should the use of treatment guidelines be used to guide health professionals on how health cases must be treated and dealt with? My question to the presenter again, de Klerk Foundation, under NHI, why must South Africa pursue inefficient approaches to the provision of healthcare services, which have contributed to the current challenges in the healthcare system? And the other key issues, don't you think, for instance, to argue that there was no broader consultation will be misleading to the public and the rest of the population? I say this because with the green paper, white paper, and now the bill, and all these issues was in the public space, there was processes of which organizations such as yours even make a presentation to argue against the HI. It is very disturbing that in final analysis, where we were at the end of the bill, you argue that there was no consultation, yet some organizations such as yours would have participated through all these processes. If you may clarify, please, because to mislead the public, I don't think it's something good to do. You also raised the issues of the Canadian law. I don't know whether the Canadian law is similar to South African Constitution, because I think ourselves, we depend on the Constitution of the Republic and also the policy that we need to do. To argue that it will not work, it will not be sustainable. We have made some pilot projects. We have seen what the weaknesses are, and we believe ultimately at the end of the NHI bill, those issues will be addressed. And that's why we're engaging with organizations such as yours in the consultation. Thank you.
Thank you very much, Honorable Chairperson. Let me also welcome the presentation from the de Klerk Foundation. I've got just few clarity-seeking questions. The first one, Honorable Chairperson, the de Klerk Foundation has cited some figures which are deemed to be associated with the NHI fund. And reference is also made to the Davis report. What I would like to understand is whether the foundation has made any effort to investigate the source of these figures in relation to whether they are based on the cost of healthcare in public sector or the private sector. And have you borne in mind the differences which exist between cost of healthcare in these two sectors? Put differently to the presenter, is the foundation aware that the figures quoted would look very different depending on where the researchers decided to retrieve their data to inform their calculations? My second question, Honorable Chairperson, to the foundation is there any enabling legislation that the foundation is aware of that includes information on costing and actuarial figures? Then my last question, Honorable Chairperson, to the foundation is Section 22 of the Constitution does indeed provide for individuals' rights to freedom of trade, to freedom of occupation, and freedom of profession. The provisions in the bill provide for the various components required to establish a functional fund that properly performs strategic purchasing to realize value for money and the best health outcomes for the entire population. In my reading of the bill, there is no provision that says it is mandatory for all suppliers and providers to participate in the National Health Insurance System, except that if they choose to, they must meet certain requirements, which is a norm even in the current business environment. Why does the foundation seem to be opposed to this? Thank you very much, Honorable Chairperson.
Now, Umamhlenga must indicate if she's able to come after Honorable Chirwa, because
yes.
Okay, I'll
yes,
give
I'm back.
Honorable Chirwa. Okay, you'll come after Honorable Chirwa, ma. Okay.
Okay, thank you.
Thank you very much, Chairperson. I was not going to take offense if you had allowed her to speak because she had a technical problem. But anyway, thank you very much for the opportunity, Chairperson of the Portfolio Committee. I think, you know, I'm getting very concerned. I'm actually very concerned with the presentation that was given to the Portfolio Committee today by the de Klerk Foundation on the particular point of insinuating that the NHI would destabilize the private sector and that people who are already using the private medical care would be compromised by access being opened up to everybody else. And then let's say the NHI was really as idealist as it's made to seem, then it would mean that more people would be able to access private healthcare, which is something that the de Klerk Foundation is finding to be a concern for them because it would compromise the access of those who are already accessing private healthcare. It's ironic, firstly, because the state, so the public sector funds the private healthcare sector as is already, regardless of the fact that it is only catering for a 10% population, right? And this over and above the fact that it is almost an equal amount. So it's close to 200 billion that goes to private care sector and then 250 plus to the public healthcare sector. So the ratio is already done in favor and bias of the private care sector, even on the side of the state. So there's already been a favoritism by the state in this particular instance, historically and currently, and that the NHI idealistically would seek to want to correct. In fact, if anything, what the NHI or the people who are most compromised by the NHI is not people living in cosmopolitan areas or urban areas the most. It's people living in rural and township areas who will still be subjected to the referral system, as the NHI does not speak on anything regarding fixing the infrastructure in the public healthcare sector. But the fact that there's going to be a referral system, meaning your closest point of a healthcare facility or closest point of healthcare reference is where one should go. In township areas, there is no Mediclinic or Medforum. Those kinds of hospitals are found in suburban areas and in cosmopolitan areas. So if there's anybody we should be concerned about in relation to access, it should be the people in township and rural areas. And the fact that even in the instance that the NHI would be idealist, would be the most equitable proposition, which is not, but let's say it would have been, then that would mean people will be able to access any healthcare facility that they would want to access. Why would that then be presented as something that would be of concern when people would have access to quality healthcare? It sort of sounds to me that this is a sentiment of swart gevaar, and I'll explain why. Because the people who are meant to be corrected, the people who this particular bill is keeping in mind, are the people who do not have access to quality healthcare. And those are people in rural and township areas, meaning Black people. So if the probability of Black people accessing quality healthcare and not having to pay exorbitant funds, which even that 10% has to be subsidized by the very same poor people to access their private healthcare. How is this sentiment not problematic for the de Klerk Foundation, number one? And number two, if your issue is access to quality healthcare, how are you not concerned about the people living in rural and township areas in this particular instance? Thank you, Chairperson.
Thank you. Come, Mama Shengwa.
Thank you, Chairperson. Let me apologize about the problem of electricity. Thank you. Let me welcome the report from the FW de Klerk Foundation. But I have a couple of questions. Chairperson, at present, we have the rule of law, but we have no equality when it comes to access to health care. If we go back to the drafting of the Constitution, we will find that the rule of law was included to prevent abuse of power as it happened under apartheid. We also find that the right to equality and the right to access to health care included to address inequalities under apartheid. Since today, we have the rule of law, but no equality in the health care. What does the FW de Klerk Foundation say about this when it comes to NHI? Does the rule of law prevent this parliament from bringing inequality in health care, or rather will it be correct to use the rule of law to block the NHI? Thank you.
Yeah. Thank you very much, Mam Shengwa. From my side, as I indicated before we started with the members, when this bill was brought to us as parliamentarians, by the way, it is not our product, and we are not necessarily defending it. We are listening to your views, all of you, and therefore wanting to make a final determination as a portfolio committee. We had to consult and ask Department of Health, have you received any legal advice with the document that we are bringing to us? As I indicated, they brought to our attention a state law advisor who had certain things to talk to us about. Now, we will have to juxtapose that with what you have as presented here. And most of us are not necessarily legal fundis. We'll also get our legal advice in Parliament with those issues. But let me just say, they gave an indication that they have gone through the legal processes of that. So that part is taken care of from their side, the sponsor of the bill. I don't know how many of our members had a call over the past few days. I did get a call yesterday from our medical aid PARMED, who were asking me to increase my premium on the basis that specialists have gone to court to ask that they want to charge as well up to 500%, something like that, quite an exorbitant figure. All it says that specialists have actually gone to court and they have been granted the permission to charge as they wish, whether 200% or 300, whatever that it is. Now, I am bringing this to the presenter because you are quoting section 18, everyone has a right to freedom of association. And you move further to say every citizen has a right to choose their trade, meaning even the medical doctors, occupation or profession freely. The practice of a trade, occupation, or profession may be regulated by law. Now, we are now saying after choosing your profession, it still has to be regulated by law. Now, why should we say things should continue as they are? Because here we are trying to get a law that will protect citizens, that medical specialists, including GPs, cannot and should not charge as they wish, but must also be within. Now, this is just opposing it with section 27, again, on this very document that you made reference to, where it therefore says, section 27 in brackets 2, the state must take reasonable legislative and other measures within its available resources to achieve the progressive realization of each of these rights. One of those rights above is that everyone has a right to have access to healthcare services, including reproductive health care. Now, the state must take reasonable steps to do that. How then do you deal with that part in that way? My last part, again, which touches on your desire for freedom of association. I think one notes your comments with regards to the selection of the Benefits Advisory Committee. Suppose there's one day a unanimity and an agreement that it is to be selected in this way, because that we are not questioning the value of the Benefits Advisory Committee. Among other things, one is expecting that that committee will do is to agree on what is the comprehensive health services for the country, for the citizens. And there's an indication in the bill that the bill might be maturing to be fully matured at a particular stage in our lives. And once that is fully implemented, then there will probably be no need for me and you to have access and other services elsewhere. Would you find it possible that there would be time when there would be no need for a medical aid schemes because all your needs, yes, I don't mean in the initial phase right now, like Honorable Chira was making reference to, there's still poor infrastructure here and there everywhere, and that under the Presidential Health Compact must still be addressed also by the Office of the Health Standard Compliance. But at a particular stage, there should be some fully implemented NHI, and then one would argue that probably at that time we will not need medical aid schemes. What is your view on that? Can you assist us with your responses, therefore, on all what our honorable members have asked? And I hope we will be able to do justice. We'll allocate you just another 15 minutes. Please don't go to more than that. Thank you.
Honorable Chair, thank you very much, and to all honorable members, thank you very much for your input and for your frank and excellent points. I can perhaps start off. As I've indicated, I'm by certain no means an expert in the medical field or an expert in the economics of the provision of healthcare or the provision of universal health coverage, as most of you are involved with, in particular with this bill and in this long process. What I would like to make clear from my side, but also specifically from the foundation side, and if you will all bear with me, I'm hoping that I really get to everyone's questions and answering them satisfactorily. But perhaps if I provide certain answers, there will be overlap in my answer to some of the questions that that overlap in a similar fashion. If I could start off this way as a general comment, the foundation is fully supportive of implementing Section 27 and really access to healthcare for all South Africans. I mean, the foundation, like all South Africans, we are aware of South Africa's dual system of healthcare delivery, the private sector and the public sector, as well as the disparities that exist in a number of respects between private healthcare and between public healthcare. And also, we are very alive to the fact that often finances do play a role in what you are able to access. So it's all good. And I hear it, and tying into what the Honorable Chair said as well, some of the other honorable members as well, you know, it's good and well to speak of Section 27 and access to healthcare, But that's exactly why we're having this discussion, isn't it? Because some of our citizens, despite the wording of Section 27 of the Constitution, is having difficulty accessing adequate healthcare. And we don't need to elaborate too much on that. What I will end off with, or what my general comment before I start, is that the Foundation most assuredly is in support of providing healthcare and universal health coverage to South Africans of an appropriate professional standard. It's not that we are against this. And I think what I can also say is that in questioning, and I say this very respectfully and in a most constructive way, that in questioning a number of aspects of the NHI bill as it currently stands, does not mean the Foundation is against implementation of the concept of universal health coverage as it is envisaged in a number of respects by the NHI bill. We are for the advancement and for the promotion, and we support this access to healthcare and by way of universal health coverage. I think it's just a question of raising certain concerns with the bill as they currently are, and then finding a way, in a constructive way. And this discussion we are already having, and discussions you have had with others and with others you will still have. This is a way of finding these constructive answers to some of the points that are raised. So please, from my side and from the Foundation, I can strongly indicate us raising concerns as a unit to certain aspects of the bill does not mean we are against the promotion of the best healthcare for all South Africans, considering and knowing full well what the disparities and the problems are. I will admit, perhaps then, to go on a number of questions raised by the honourable members. I couldn't finish writing down the question posed by the first member. If you will bear with me, perhaps, if possible, to put that in the chat box and I can respond adequately. If I could move on perhaps to respond to the question, the second question, or posed by the second member, in that the view she got, or the impression that she got, is that the Foundation is in some way advocating that the NHI is divisive, and that there's a number of political aspects involved, and whose political interests are we advancing, also perhaps by way of our submission. In an effort to perhaps address this question or this concern, by no means. The Foundation is an apolitical organization. We're a non-profit organization, and our mission, our core mission, is to advocate the Constitution, the Bill of Rights, and South Africa's success story flowing from the CODESA negotiations and ultimately resulting in our progressive constitution. So we by no means couple ourselves to politics. So in us submitting and providing this submission, honourable members, and to the honourable member posing this question or concern, there's by no means in our submission no specific political agenda that we are advancing. If I can maybe tie this off, the agenda, if I could call it the agenda, or the message that we are trying to advocate, is that we feel very strongly about implementing Section 27 and access to healthcare, and then also the concept of universal health coverage and better healthcare for South Africans, not just those who can afford private healthcare, but also those who are reliant on public healthcare. In a sense, our message is advocating the Constitution and the Bill of Rights. And I think in trying to say that in us raising certain concerns about the NHI bill, it's not being against it. It's questioning perhaps raising some flags and concerns as to what would be the best way forward, and raising the question whether the NHI in its current form is the only way of how to make South Africa's delivery of healthcare services to South Africans. Is this the best way to do it? And that's why we are having this discussion. Perhaps to move on to the questions or some of the concerns posed by the third member, relating to the green paper and white paper, and then also the British situation, and also the member having made reference to the Genesis report, NHI pilots, perhaps in a way to, and also to address the chair's time concern, perhaps to address this in a shorter way by looking to the British situation. Most certainly, Britain after the Second World War, as indicated with their NHS system. Perhaps what I can raise here, and I do so very, very respectfully, because relating to a question that a different member of the panel posed regarding whether we are the same as Canada and whether we have the same law as Canada. In a juxtaposed way, in a converse way, I can perhaps refer to the British situation by simply saying the concern I have here is us looking to perhaps as a country implementing the NHI as opposed to the British NHS after the Second World War is unfortunately, and here we must be honest with each other, we must look at the situation at SAA. We must look at the situation at ESCOM. We unfortunately, and in trying to answer and address this concern, this is perhaps where the South African situation, even though we have not exited from a war situation, it's perhaps a war on a different kind of battleground, a war against mismanagement, a war against corruption, against maladministration. And perhaps the British, even though they came from a physical conflict situation, implemented their healthcare system, and it went from where it was to what it is. I stand corrected, but it does not seem to me that even if Britain came from a physical war and conflict situation, that their state-owned enterprises were in such unfortunately, in such a mismanaged position, such as ours, and that their infrastructure, the infrastructure reliant on SOEs, was so in the grip of corruption and maladministration to the level that it is effectively on the verge of breakdown. So that perhaps trying to clear up that concern, perhaps to move on to some of the questions posed by the fourth member of the panel, and thank you. Whether in our view the bill protects the fund from corruption and maladministration. Perhaps to answer this in a two-pronged way, it's a yes and a no. I think I will stand by the foundation submission. This also ties into something that I think it is the chairperson, the honourable chair, that raised this. Is it not adequate, as the NHI bill proposes in its current form, that the member of or that the Minister of Health should be the custodian of this process and of this bill and of this fund? Is that not proper, considering the portfolio? On the one hand, yes, there is a proper sense of that being so. I think what we are concerned with, and again, tying back to South Africa's unfortunate situation and the current reality on the ground of rampant and severe corruption in a number of state-owned enterprises. Cadre deployment has done immense damage on a number of levels. We've seen this, all South Africans, regarding where you are from. We all have seen the damage that have been done to a number of SOEs. So yes, on the one hand, I would agree that to a sense, it would make sense that the Minister of Health is the custodian of such a process and of such a fund. But I think we would stand by our submission, Honourable Chair, and to the Honourable Member that raised this concern, that we feel, although such a person could be a proper custodian, there should be more adequate checks and balances in place to balance out this range of power that is afforded in such a custodianship and in such a custodial position. And we think this would be ultimately not just in government's favor or in anyone's favor, but ultimately also to the people on the ground at the consumer end, who will be the consumers of the medical services provided and the medical services delivered. So we feel that even though such a person could be that custodian, yes, there needs to be a more transparent and a more broad system of proper checks and balances to dissipate that power from that one office to a more accountable system. Something that I would like to respond positively to, it was a second question from the fourth member. Yes, we made the submission in our document that we see it as a regression, that the process of appointing the board, the NHI board, is now that basically flows solely to the minister. I would agree, and I think it would be a strong step, a positive step, if there's parliamentary oversight or a public parliamentary process for appointing the board. I think that could make sense. There were a number of other questions. I think I've addressed this to an extent, and I hope I do so respectfully. Do I support, or does the foundation support the NHI in its current form? I think our submission makes it clear that although there are a number of very positive respects, and this also ties into something else that one of the members, I think it was Member Chirwa, that she raised, although we raise a number of concerns with a number of what we view are could be problematic operational concerns in the bill, we do feel that there are positive aspects of the bill, but we do raise the question, is this the only way forward on a proper balancing of rights between the public and the private sector? And then perhaps to address the last issue raised by the fourth member, what is the Foundation's view of a single purchase model? I think without going too far, perhaps just to shed some light on this is what we've seen now with the recent COVID-19 vaccine rollout, and what the positives and or the negatives, because we must be realistic with each other. There were good things about about government's COVID-19 vaccine rollout, but there were startling inadequacies in that process as well. I'm not here to judge this process, because what effectively happened, government, and this is why I use this as an example, government turned itself effectively as regards COVID-19 vaccines into a single purchase model. And there we've seen a couple of good things, but we've also seen what the severe problems with this could be if there is a single provider or a single purchase model. And I think, and I could respectfully perhaps submit, that should the state or should government with something like NHI become a single purchase model, that is why we ask so strongly for adequate and proper, strongly entrenched modes and methods of accountability and checks and balances, so as to avoid some of the negatives and some of the negative implications and effects we've seen, for example, as with the COVID-19 vaccine rollout. To move on to some of the concerns, and Chair, I beg your pardon, you must stop me if you feel my time has been meted out. There's a sense that the Foundation views certain constitutional rights as absolute, and that why can't certain rights be tempered to accompany the broader good? By all means, we have a Bill of Rights for a specific reason, and that is to protect the citizenry from inadequate government infringement. This is on the balance of rights. We are certainly, as it's indicated in Section 36 as well, upon a proper construction where the enforcement or the promotion of one right is needed at the cost of a different right, then it's a balancing act, as it is explained and set out in the Constitution and in terms of Section 36. So we are by no means advocating from some sort of boxing glove corner that certain rights can't be touched or are absolute. They must be treated according to Section 36 of the Constitution and weighed up appropriately against each other.
Yeah, okay, wrap up in 3 minutes, in 3 minutes time.
Thank you, Chairperson, for that indication. Perhaps to address a second concern here raised by the fifth member, why do we cite Canadian law? Perhaps just from a legal perspective, South African jurisprudence often draws very positively on Canadian law, also Indian law. So I know a lot of judges and our justices often draw for guidance on Canadian law and on Canadian jurisprudence, also because their constitution is similar to ours in a number of respects. Ours, as well as the Canadian constitution, are considered to be very modern, very progressive. So perhaps just an indication in that regard. To move on to Chair to question 6 or what was posed by the 6th member. For everyone and for the rights of everyone in this regard. Chairperson, I think I'm running out of time. I would love to perhaps respond to the other questions, but I do not want to take up unnecessary time. I think would it be possible for me to wrap up?
Please go on. Then we look like at 11:40. We give you a stop, real stop.
Thank you. I will keep an eye on the time, Chairperson. Thank you.
Yeah.
Perhaps to just, there was a concern from the 7th member of the panel. Specifically, I think this was Honourable Member Chirwa. Specifically, also how this situation, she made reference, if I recall, to, of course, there's mediclinics and private hospitals and healthcare facilities in big urban and suburban areas, but this is unfortunately not always the case in urban areas and in, I beg your pardon, in rural areas in South Africa. Most certainly so. I agree with you, and this is exactly why new suggestions and a new plan is needed. And perhaps in a number of ways, Honourable Member, the NHI is the framework to address this disparity between delivery of these healthcare services. But we want to just leave the panel and Honourable Members with the question that although the NHI might be a framework to do so, it ought not to be a framework that completely does away with the existing system, or at least, if I could rephrase that, with the positive aspects of the existing system. I think what I can perhaps just quickly refer to here by way of clearing this up and this submission, look at the recent or the recent suggestions on the new land court and the land court bill. South Africa has a system of the land claims court. And now there's a new system and a whole new system coming, a whole new court system, basically in essence, as it's put out and envisaged in the land court bill. Why do I raise this? That bill and proposing that new court system, it basically looks at almost overhauling completely overhauling the whole system. In other words, completely removing the land claims court and all the progress that it has made, yes, taking into consideration the concerns and the negatives, but completely doing away with the positive aspects and dynamics of that system as well. Now, to bring this home into this discussion, I think a question the Foundation can leave with, and that we have tried to put forward in our submission, is yes, most certainly, if we start at section 27, South Africa has a healthcare system and a problem with our healthcare system where not all South Africans can access quality healthcare. This problem needs to be addressed, absolutely, and we agree with that. The question is how, and then the further question of how is, do we completely, with, for example, the NHI, do we completely do away with the existing system, including the positive aspects thereof, and implement a new untested system, which will have immense fiscal implications? And should it fail, I'm not even going, as indicated, I wish I was an economist as well. One can try and project the fiscal implications should the NHI system not be implemented properly, and should it, hopefully unforeseeably, but should it not function effectively. So I think I can end off that submission by saying, yes, the positive aspects of the NHI, of course, it should be considered to address South Africa's inadequate medical or healthcare system. But is it the only way? And from the Foundation side, we feel that we should consider all alternatives, and also in considering all alternatives, there might be the need for further consultation, especially with the healthcare sector and the healthcare industry. As I've indicated, for example, the concept or the idea of a consultative forum before the NHI is implemented. I think this touches on what one of the other members raised. Thank you for bearing with me. I think that is also why, from the Foundation side, we raised a number of suggestions of, for example, strengthening the Office of Health Standards Compliance, the OHSC, as an independent body, and also the current Health Ombudsman. I think there could be real value in leveraging all and strengthening the capacity of all these existing infrastructures before simply trying to do away with it and overhauling it into a new system that we don't know what the fiscal implications are going to be. Chairperson, I think that brings me to 11:40. I apologize if I've not adequately addressed the concerns of all the members, but as I've said from the beginning, I thank you sincerely for affording me the chance and for affording the foundation to engage with you and with your portfolio committee members on this most important aspect for all South Africans. I thank you very, very much.
Put it at the end, would put at the close with you. Thank you. I would really wish that you continue also engaging with the Department of Health as a foundation, so that maybe some of the issues that are of concerns can be attended to even at that level. There seems to be a suggestion that everything that is good will be thrown away. It doesn't look like that is what the bill is making suggestions on. That is why among other things, we are right. The ombudsperson, the Office of the Health Standard Compliance is in place. The Presidential Health Compact are some of the enablers to make sure we traverse this road in that way. But thank you very much for your contribution. And I'm glad you were not threatened by members asking you questions. You were brave, able to come back. Your initial fear that they were going to actually deal with you badly is not actually fair. So I hope they treated you well. You are able to confirm that.
They were like surgeons, Honorable Chair. They were like the surgeons they are. I thank you for your time. Thank you for your input. I wish you well with the consultative process. Thank you.
Okay, thank you very much, and then have a good day.
Stay safe.
Honorable members, we will not take a break. It will be just a stretch break as they loading the presentations of the Helen Suzman Foundation. But let's maybe give you 3-4 minutes to start exactly at 11:45. Just take a couple of 3 minutes but please do the sharing of the screen so that we start immediately at 11:45. Okay, thank you very much. We welcome you again to this second presentation. We welcome the Helen Suzman Foundation and those who have been tasked to come and present. You are meeting a portfolio committee of health in the National Assembly that is looking into the NHI bill. We will welcome you to make your inputs with regards to that. Firstly, you'll introduce your members who are logged in, and then you'll have 45 minutes to make a presentation. The members will then interact with your presentation in the clarity-seeking questions, and then you'll come back to respond to those questions, and then we'll bring it to a close. So your 45 minutes starts now.
Thank you very much, Chair. I'm Anton van Dalsen. I'm a member of the Helen Suzman Foundation, and I will be making the presentation. My colleagues Sophie Smith, Zinat Imamali, and Charles Simpkins are also in the meeting. I have a presentation. Shall I put it on the screen and then proceed from there?
If you logged in after I had asked that it be done before we start, it should have been done.
There we go.
At 11.
Do you have it on the screen? Do you have the presentation on the screen, Chair?
We don't.
You don't? I've got it on my screen, and I did send it through beforehand to your to the administrators.
Lindokuhle, what is the situation here now? When we took a 3 minutes break, I asked that it be shared, the screening be shared, and this presentation be loaded already.
Is it on now?
Yes, yes.
Good.
Can you put it on a slideshow?
There we go.
Yes, there you are.
Okay,
Yeah.
good. So this is the presentation of the Helen Suzman Foundation. And I think to start with, just to make it very clear, we absolutely support the goal of universal health coverage, and as subscribed by the World Health Organization, for quality, affordable, universal health coverage. So as far as the principle is concerned, we support it. However, universal health coverage as set out in the NHI bill, we feel can only be implemented in an effective manner if the existing very substantial problems within the South African health sector are first addressed, together with a range of other issues which the NHI bill and government policy have not taken into account. And I'll go through all of these in a little bit of detail in the presentation to make it clear. I think the first big problem is the reality of the South African public health sector. We have the clear opinion that the quality of healthcare in the public sector is on the whole unacceptable. The Office of Health Standards Compliance, which is a public entity, found in its most recent inspection report, this goes back a year or two already, that out of 730 public sector health establishments that they inspected, only 19%, 19, were compliant with required norms and standards. Now, the background to this is set out in some detail in an earlier report of the OHSC, and I'll read that because I think it is very important. They found there that in the public health sector, leadership and management, including operational management, was poor or lacking, leaving subordinates without the required level of supervision, knowledge, competency, and support from senior staff, including clinical professionals. Governance structures in the greater number of health establishments were not available, impacting negatively on leadership. Where governance structures were in place, there was no evidence that they provided oversight to ensure quality care, accountability, and good management. So I think just to summarize, the issue there is one of management not being up to standard. That is the public health sector, the major problem. And the other one major problem is the reality of the South African private health sector, where the problem is slightly different. And here, the health market inquiry into the private health sector found in 2019, the state had failed in its duty to regulate that sector in an adequate manner. The health market inquiry found that the sector, this is now the private health sector, is neither efficient nor competitive. And it also found that the private healthcare market is characterized by high and rising costs of healthcare and medical scheme cover, and significant overutilization without stakeholders having been able to demonstrate associated improvements in health outcomes. And just to give a little bit more detail, I'll refer to one or two more specific things to illustrate the problem with the private health sector. And firstly, there's a serious problem of over-servicing. And there's no teamwork principle applied in the private health sector. And it's characterized really by standalone practices. Secondly, you have the phenomenon of specialists effectively acting as primary healthcare givers instead of GPs being given that role. And it's obvious this leads to a massive financial drain. And then thirdly, very important, is that hospital admission rates in the private sector were far higher than can be explained. And the excessive utilization there leads to a very large driver of extra costs. So these are very serious problems. And I think that added to all these problems, we find that our clear impression is that there's been very little consultation with the private sector in putting together the NHI concept. Now, within the NHI, the private health sector will continue to play an important role. And it's very important that there's a buy-in by the private health sector into the NHI's principles and operational structure for it to function properly. It's therefore astounding that minimal consultation has taken place in this regard. And I can just point out that high-profile gatherings under presidential auspices, which serve the basic purpose of promoting government's own views, cannot be regarded as true consultation. So we find that the essential problem in trying to deal with the NHI bill is really, therefore, that a funding and payment mechanism is to be superimposed on two badly functioning components. And these two badly functioning components are, firstly, the private, and secondly, the public health sectors. And I've tried to illustrate what the problems are in each one of those. And it's nowhere explained how the NHI will effectively transform these sectors into an efficient set of healthcare providers. The impression, therefore, cannot be avoided that the underlying intention of the NHI bill is only to create a funding and payment mechanism with little regard as to how healthcare is to be transformed. So we find that that is the essential problem. And I will now go into a number of associated issues which need to be considered as part of the further progress of the NHI bill. Now, the question as to what will the NHI cost? Now, government has not provided any estimates in this regard, and the details provided in the memorandum which is attached to the NHI bill under the heading Financial Implications for the State only provides estimates of a few items of preparatory costs. It therefore gives no real insight as to what this is going to cost. And the public therefore has to be content with statements of the following nature, and I've taken two statements there. The one is from Dr. Crisp, who's heading up the NHI initiative within the Department of Health, and that I'll read it to you just to show you what kind of comments we are confronted with. In a public meeting, he said, "How long is this going to take?" This is now the NHI. The answer is a long time. We don't know all the details of what it will look like in the end. What we do know is that we are going to have to be flexible. What is it going to cost? It's going to cost as much as we can afford, full stop. That was Dr. Crisp. And the other quote that I have there is from Dr. Olive Shisana, who's Special Advisor on Social Policy to the President, where she was, in answer to the question, how much is this going to cost? She said that the demand that the NHI bill should indicate costs is unfair because costs change over time. Now, I give you these two quotes just to illustrate what we are confronted with in asking what is it going to cost. And I'm afraid that statements of this kind cannot really be taken seriously. The associated problem is that there's an absolute absence of a detailed feasibility study for the NHI. Now, it's inconceivable that a project of this magnitude could be seriously considered, let alone implemented, in the private sector without a comprehensive feasibility study, including various scenarios to indicate what the associated costs would be for different levels of care. And it would be logical for estimated costs to be provided as part of such a feasibility study to cover, let's say, at least 3 scenarios. First, if the NHI were to cover only very basic services, in other words, a low cost. A second estimate would be at an intermediate level of cover, where they cover some costs but not all. And finally, if the NHI were to cover all health costs. Now, we have no idea what the costs on all these levels are supposed to be. And we can only confirm that no such feasibility has been completed and no cost estimates of this nature are available. And even if the cost estimates are approximate or within a certain range, it would be helpful, but nothing is available. As far as the NHI's administrative requirements are concerned, with 60 million potential users, in other words, the whole population, about 220 healthcare practitioners and a multitude of public and private healthcare facilities, any institution that manages a payment and quality control system to cover all of these has a massive administrative task, requiring an adequate number of competent workers and experienced managers. This very substantial administrative structure has to be started from scratch. No details are available on its planning and progress. As far as the governance issue is concerned, the NHI bill makes it clear that all aspects of governance of the NHI depend on the Minister of Health. Now, clause 27 of the bill does provide for the Minister to appoint a stakeholder advisory committee comprising representatives of statutory health professions councils, health public entities, organized labor, civil society organizations, associations of health professionals and providers, and patient advocacy groups in such a manner as may be prescribed, as the bill states it. But no clarity whatsoever is provided as to the duties and responsibility of such a body. Now, the proposed governance framework, therefore, has no independent content of any real substance outside of the minister, and we feel this is not acceptable. So what needs to be done is, I think, first of all, Parliament has a real role to play there. And secondly, we feel it's absolutely essential for independent bodies to be part of the overall oversight system in such a huge project. The role of private medical schemes, this is another issue which needs to be raised within this context. And that is that the NHI bill and memorandum offer no justification as to why private medical schemes are to be prohibited from providing cover for services that are covered by the NHI. Now, the NHI is to be funded by taxes, but government clearly intends to prevent taxpayers from exercising their freedom to choose whether they also wish to insure themselves independently from the NHI for these services. And this would obviously be at the election of such consumers and at their own cost. In other words, they would be paying their taxes, which would fund the NHI. But if they want to, over and above that, still insure themselves privately, we do not see why they cannot do so. And the comment we feel necessary to make is that in the absence of any justification for such a prohibition, we can only see this as irrational conduct by government. So we come to the question, what needs to be done? And I think before commencing with the implementation of universal health coverage and the NHI bill, the following has to be done. First of all, a properly functioning public health sector service. Secondly, a properly regulated private sector health service. So in other words, both the public and the private components of the existing health service need to be regulated and function properly before the NHI is implemented. Thirdly, there has to be a substantive consultation with the private sector. Fourthly, there has to be an acceptance of the principle that individuals must be permitted to subscribe to private medical health insurance, as their tax payments will already fund the NHI. So it's not a question of them choosing which one their money goes to. Their money will obviously have to go to both if they want private medical insurance. Then there has to be clarity on the cost of the NHI, estimated on the basis of a comprehensive feasibility study. And there has to be confirmation that it is actually affordable by the state. But at the moment, we don't know what it's going to cost, so nobody's actually able to answer that question. Now, if all of these things are not done, the passing of the NHI bill and its attempted implementation will not only not succeed in its objectives, but it will inevitably lead to a further degradation of both the public and private health sectors in the country. And our very clear view is therefore that the NHI bill needs to be reconsidered against this background, and a number of issues, a number of which I have raised in this presentation, absolutely need to be redone or fixed up before the NHI bill is put before Parliament to be passed. We feel it is absolutely necessary that these things have to be done, and that it is premature for the NHI bill to be going through Parliament at this stage. Chair, that is our presentation, and I'd be happy to take questions. Thank you.
Honorable members, I will be taking your hands because I haven't seen in our chat group those who would like to, oh, there's one now that has come through. Let me then take it there, not put it down anymore because there was a delay. There's one that has come through. Dr. Jacobs is number one. Who wants to come in also is number 2, 3? Can I take those hands here? Don't write it down. Mahlengwa, you are number 2.
Aye.
Please don't, honorable members, don't write it anymore on the platform. I'm taking it here now. Honorable Gela, you are number 3. After Gela,
Munyai.
Honorable Munyai, I'll give you number 4.
Dr. Harvard.
Dr. Harvard, you are number 5. Any other hand? The first one is Dr. Jacobs, followed by Mama Shengwa. The third one is Honorable Gela, followed by Honorable Munyai. And the last, who is number 5, is Dr. Harvard. Mr. Dalson, towards your close, you wrote very 3 points. I want to bring it to your attention that there are certain presenters who have come to this portfolio committee. Some of them are saying, but we were there on the white paper and there seem to have been changes or certain things that we raised on the white paper now on this final bill. It presupposes that there were people who were interested to bring their views during the green paper, the white paper, and now the bill. Now it actually goes back to you that says, how long is this piece of string of consultation and what form of consultation should it be?
Chair, I'm sorry, I can't hear you to the moment.
Oh, you can't hear me? Yeah, you don't have to answer now. You don't have to answer now. You'll answer when all other members' questions have been posed. But I said it caught my attention towards your close when you said there has to be extensive consultation of the bill. Now I'm saying to you, there are certain presenters who came to this portfolio committee making reference to a particular point and saying, this point on a white paper was written this way. Now we see a change in the way it is drafted, meaning that there are South Africans who took an interest in the consultation during the green paper, the white paper, and now the bill, which negates the fact that there were no consultations. I'm just raising that one. I was not part of driving the consultation in the country on this bill, but it actually boils to say there are certain South Africans, probably not Mr. Dalsin, who are aware that there were once consultations on the green paper and they made their inputs. It went into a white paper, they also made their inputs. They are now saying, look, we look at this bill, this is different here in terms of the wording. Can we raise that as issue? I'm just saying, you come from a platform where you are saying there's been no consultation or little, and there are other people who are saying there were consultations to this level and we made our inputs in this regard. You don't have to reply now. I'll give these honorable members time to also ask you questions, then you could then come in. The first one is Honorable Dr. Jacobs, followed by Honorable Mashengwa. Third is Honorable Gela, followed by Honorable Munyai. The last is Honorable Dr. Harvard.
Thank you, Chairperson. And
I've also noted on the group chair for a question, please.
Yes, I note you, Honorable Sokacha. I said Honorable members must not write on the group anymore because we were late. Okay, you are number 6.
Thank you, Chair. Can I start?
Yes, sir. You can start, Dr. Jacobs.
Thank you very much. And thank you very much for the presentation this morning. And Chair, you just touched on the first question that I wanted to raise, but I think maybe I should just follow it up with what the process was to date. And this process started in August 2011 when government published the green paper on the NHI for public consultation. And then it was followed by detailed consultations and discussions across the country with a wider variety of groups, including academia, the private sector, civil society, national and international health experts. And 150 submissions and 168 consultative meetings were then had and received. And the number of attendees over that period were 59,000 attendees. In 2015, the white paper was published for additional consultation, followed by the publication of a second white paper on the 28th of June 2017 for more consultation. And then we further from 2019, we have embarked on a thorough process, starting with the public hearings in the provinces to having process which we are now having at Parliament. And so it does speak to your point and my point of the question raised by the Helen Suzman Foundation that there was limited consultation. And then, Chair, the foundation also highlights challenges facing the public sector facilities. It's also highlighted in previous submissions that there's a tendency for health professionals to migrate to the private health system instead of working in the public health sector due to the high reimbursements which are received in the private sector. Is it correct that the foundation's observations are deemed to be surprising? And would they be willing to acknowledge that the very reason for introducing the NHI systems are exactly because of the inequalities and challenges highlighted by the Helen Suzman Foundation here today? Chair, if you just bear with me, I have 2 more questions. The Helen Suzman Foundation has also made a decision that it is inconceivable for the private sector to take the NHI seriously, and neither will they implement any of the proposed provisions of the bill. The question is whether the foundation is advocating for the continued fragmentation of our health system, which is known not to work for the majority of South Africans. Is the foundation therefore presenting a view which suggests that they are lobbying the private sector not to take this reform seriously? It also appears that the foundation finds it impossible to see a non-fragmented health system in South Africa And this is because throughout their presentations, even when the proposals are made on the bill, which relate to corrections, which should be made either in the public or the private sectors that we already know do not serve the interests of the South Africans, that they do not make concrete suggestions towards that. And is there any reason for the foundation to prefer this approach in dealing with our health challenges? Thank you very much, Chairperson.
Mashengwa.
Thank you, Chairperson. Let me welcome the presentation. The Helen Suzman Foundation dubbed whether the state will be able to fund NHI. Is this a legitimate concern? It is even honest to believe that this parliament will adopt NHI legislation when the state has no money for it. Thank you.
Honorable Kela.
Thank you, Chair. I've got a few questions that I want to ask. My first question, you're concerned about the future role of the medical schemes are noted. Some of the stakeholders informed us that over the years, the cost of private health care have been increasing, and that medical scheme members are not well protected. They are running out of the benefits before the end of the year, which is a problem really, because they end up going to the public health facilities. There were also complaints about serious governance challenges in the industry. This observation was also made by the Health Market Inquiry. Based on this, I have the following question. In your view, does this situation not threaten achievement of universal health coverage? Are you also aware that the white paper provided an analysis of different roles that schemes can play based on international best practice? What is your view about people insuring against the same healthcare cost twice? By this, I mean a duplicative cover or a double dipping. Does this not lead to insufficient health utilization? Will this not perpetuate the current inequities, hereby threaten achievement of universal health coverage? That will be my first question. My other question that I want to ask, Chair.
Are you still there, Honorable Kela?
Yes, Chair. The NHI bill outlines components that are intended to significantly transform the health system into a unified and equitable one. Why does the Helen Suzman Foundation assume that the intention is to simply superimpose a new funding and payment mechanism and to continue with a dysfunctional system? The memorandum to the bill clearly outline parallel reforms needed to streamline the performance of the health system, but the foundation seems to ignore this entirely. My last question, Chairperson, the Helen Suzman Foundation must be commended for articulating the endorsing the report of the OHSC in a manner the presenter has done, wherein he highlighting the weaknesses in the public sector. The presenter also seems to be well aware of the state of healthcare in the country, where the allocation of resources between the private sector and the public sector is closely skewed. My question, Chair, if the presenter has really studied the NHI bill and its object and principles, does he not believe that this NHI is seeking to address such an imbalance where the public sector will be adequately resourced and therefore provide access to healthcare to those that do not have access to healthcare? That will be my questions, Chair. Thanks.
Okay, thank you. Honorable Munyai.
Thank you very much, Honorable Chair. Thank you very much for this opportunity to allow me to speak. The Helen Suzman Foundation mentioned that the government has failed to regulate the private sector. Are they aware, therefore, suggesting that all market failures identified or investigated by the Health Market Inquiry Panel in the private sector were attributed to the regulatory failure? If so, what is their observation based on the fact, science, not fiction or myth? I would like to point out that the Helen Suzman Foundation to the Health Market Inquiry Panel which published several theories of harm way over and above regulatory failures. There was an investigation of the impact of the market power and the distortion in the competition within the medical scheme, private hospitals and the private sector doctors. The Health Market Inquiry Panel also investigated barriers of entries and exits, including imperfect information. Are you therefore aware that the panel also received number of submissions where, amongst others, issues of concern, some of the stakeholders complain about over-regulation resulting in the barriers to entry, expansion and crowding out of innovation? What is your view on these ones? It is very much important to get. But the other question, Honorable Chair, that I have for the foundation is as follows. The Helen Suzman Foundation has suggested that the government did not consult the private sector, and further that the government is using the NHI bill to advance its own views. These statements are very confusing because I thought a typical South African will be well aware of the problems we have as a country in our healthcare system. What I need clarity on, Honorable Chair, is why does the Helen Suzman Foundation not see the private stakeholders as citizens of the country who have the right to make proposal on policies the same way this foundation is doing right now? What does the foundation expect government to do with regard to NHI bill in effort to ensure that everyone exercises their rights by contributing to the discussion of this nature with regard to bill? On slide 12, Honorable Chair, slide 12, the Helen Suzman Foundation submits that 6 prerequisites that are unilaterally predetermined must be met before the NHI bill is progressed. However, evidence suggests that there's no universally agreed template that says how country must implement policies or reforms to achieve universal health coverage. Even countries that have made significant progress, many of them started their journey at the point when the economics and healthcare system were down and very weak. A good example being the UK NHS, what do they think the prerequisite they identify cannot be implemented concurrently as the NHI is implemented? Honorable Chair, the Helen Suzman Foundation.
Honorable Munyai, I will limit you to 5 questions now, because all other members, if they ask
Please.
10.
I'm not going to make up this the last 2, please. The Helen Suzman Foundation seems to believe that the rights of the consumers to access healthcare at a place of their choice is limited in the NHI bill. Can the Helen Suzman Foundation please explain how it reached its conclusion? As I do not have such recollection, it will be helpful to quote the exact section of in the bill to answer this question. The Helen Suzman Foundation seems to believe that the proposed reform is aimed at creating some form of financial scheme instead of introducing measures aimed at ensuring equitable access to healthcare services for all South Africans. My last question, Chair, will be, why does the foundation view the NHI in this manner? How does they position, how do they position the Department of Treasury in mobilizing funding for NHI among these things? Because they view to suggest that the government regulatory failure will mean really a neoliberal alternative. That will be my view, if they can clarify.
Honorable Munyai, you asked 8 questions. Now, I will plead with you in the subsequent one, because if all these members were to ask 8, we'll be having 48 questions, and we'll have to give this member an hour, which we don't have. Let me just make a correction. Honorable Keller has requested me to make this correction. It sounded like she was saying the Helen Suzman Foundation must be commended. No, she was saying the Helen Suzman Foundation must be commended for articulating and endorsing the report of the Office of the Health Standard Compliance. Yeah, just that. Dr. Harvard?
Thank you, Honorable Chair. I just have 2 questions. The first one, the Helen Suzman Foundation presentation highlights challenges facing public sector facilities. We should, however, note, as highlighted in previous submissions, there is a tendency for health professionals to prefer working in the private instead of public sector due to the high reimbursements that they receive in the private sector. My questions, are the foundation's observations surprising, and would they be willing to acknowledge the very reason for introducing the NHI stems from the very inequalities and challenges highlighted by the Helen Suzman Foundation? The second question is my understanding that the HMI recommendations are being considered by National Department of Health. However, there is no place in the recommendations that states categorically that the NHI bill must be amended to incorporate every single one of these recommendations. Is the Helen Suzman Foundation's position that the NHI bill processes must be stopped until such a point that the NDOH has implemented all the HMI recommendations? Thank you, Chair.
Honorable Dr. Harvard, you seem to have 2 gadgets that are on. Is the one that we are talking through to and the one at the background. That noise is coming in as an echo in this system. Please have 1 gadget on at a time. Honorable Sokacha?
Thank you very much, Honorable Chairperson. Just 3 questions from my side. The Helen Suzman Foundation must be made recommendations for the speedy implementation of the HMI recommendations is noted. In your view, how far did the HMI panel consider strengthening of risk pooling for the whole population in South Africa? I mean, did this investigation consider the poor, or did it just seek to strengthen risk protection and pooling for those who can afford medical schemes cover? I also understand that the HMI panel made a recommendation for the establishment of the risk adjustment mechanisms. Do you think these mechanisms will benefit the public sector? On mandatory participation recommendation, are you aware that the NHI fund recommends mandatory participation, which will benefit all, not just medical, just medical schemes members? Section 2 of the bill states that the National Health Insurance Fund will be funded through mandatory payments that aims to achieve equity, sustainability, affordability, and equality healthcare services for all. What is your view on this? Then my second question, Honorable Chairperson, the presenter referred to the rights of taxpayers to all access private healthcare services. How do the presenter understand healthcare? Does he understand it as an individual right or as a public good? Then my last question, Honorable Chairperson, to the presenter is that social solidarity is one of the main principles of the NHI. Is the presenter familiar with the concept catastrophic healthcare expenditure? This is a phenomenon where people fall into poverty because they have not used all their resources to pay for healthcare. People have sold their cars, people have sold their houses, people have sold all their belongings just because a family member got ill and they needed to take care of them. The NHI will protect consumers from this phenomenon. What is your comment on this? Thank you very much, Chairperson.
Yeah, Mr. Carlson, from my side, one of the questions I did indicate a bit, Dr. Jacobs has also touched on it. The one on the green paper, white paper, and now the bill. He was even quoting the dates and the months and the years through which the process. Now, it does look like this is not one of your strongest points, because there are certain organizations that have come in here themselves indicating that they were part of this here and there. And I was just wondering, Helen Suzman Foundation, what capacity do they have to speak on behalf of those organizations who have on their own came forward and indicated challenges that they have here and there, and their recommendations and commendations on the bill, when you are on the extreme end saying everything must be started from scratch. The second part of my question, the last one, is related to what Honorable Sokacha has ended with. When you started, your point of departure was clearly indicating that you do notice challenges both in the public and the private healthcare sector. You highlighted those in the process. But then you are saying you don't find clearly indications from the bill where it actually wants to redress these issues. Among other things is what Honorable Sokacha has indicated. There are principles of social solidarity, principles of mandatory prepayment, financial protection, universal access to health of all citizens, equity in allocation of resources, and equity in the utilization. As you are saying, there's overutilization here and there, and then seeing health as a public good. Now, those are some of the things that are unfolding according to this bill as how it will transform both public and private, because some of these things are pointers to the challenges both in the private and public, wanting to make it as an efficient system. It goes on to talk somewhere about the incremental approach it will use, where it talks that there's a desire to have a progressive realization of the rights of access to quality. And through this NHI fund, we will then promote the sustainable health outcomes. Now, maybe as it is talking as a bill, I'll be checking with you whether you wouldn't really want some of these explained further in regulations, but as they stand as principles, as founding principles of the bill, are they not probably covering your concerns if you go through them into those details? We will allocate you not more than 15 minutes to reply to these questions. I know there's quite a lot of them, but we also are pressed with time. So can we allocate you not more than 15 minutes? Thank you very much.
Thank you, Chair. I will try to deal with them, with the questions. I think there's one aspect that kept on cropping up, and if I could just make a few general comments first, which I think will deal with a number of those. I think first of all, I need to re-emphasize that the foundation is absolutely in support of the principle of universal health coverage. The problem, though, is that you have a badly functioning public health service at the moment, and you have a badly functioning private health service at the moment. So if the NHI is going to be implemented tomorrow as a funding and payment mechanism for the South African health system, it is going to fund and pay for bad public health and bad private health. So implementing the NHI is not going to solve the problems that there are at the moment. And I don't think one should confuse the principle that is being, that one is pursuing in the NHI of universal healthcare, with which we support, and we have no problem whatsoever with that. But we have a problem with trying to implement it on, or trying to superimpose it on a badly functioning health system, because purely implementing the NHI is not going to solve the problems that there are at the moment. You can have all the money in the world being thrown at a health system, but if the health system itself is not working, all that money is not going to help. So what has to be done, first of all, is that the public health system has to be fixed up. The problems are clear, and it's set out in the report that I referred to in my presentation. And that is principally a question of management. It has to be sorted out. Otherwise, you are going to pay a lot of money for bad services in the public sector. And in the private sector, the issues that were highlighted in the health market inquiry have to be solved in the public health sector. So to a large degree, these are things that the Department of Health has not been doing, and there's no indication when they will get around to it. So this is quite separate from the principle of the NHI. We have no problem with the principle of the NHI. But if I can take, it may seem like a silly comparison, but I think to make the point, if you have an old car with an engine which is really horrible and it gives you all kinds of problems, and then you go to a garage and they put a new chassis onto the engine, and off you go in your so-called brand new car. It looks new, but the engine is still there. It's not going to solve the problem. The engine is going to break down even if you've got a brand new body on the car. And I think in trying to make my point, that is the issue. It's not an issue of trying to look for benefits for with the wealthy. It's not at all. And on that issue as well, I think I need to spend some time. And that is that the funding of the NHI will come through taxes. There's no other way to fund it. Now, if taxpayers fund the NFI through their taxes, why can't they, if they still want to, that is to say, if they want to go to private healthcare insurance and want to do that, they can, because they've funded the NHI already. And if they have surplus money to spend on private healthcare, that's fine. That's what happens in the UK. A lot of reference has been made to the National Health Service in the UK. But there, and a lot of people have said, well, look at that, look at what they've done. But they accept private healthcare because the NHS is a government-funded entity. But if you want to spend, I don't know how much on private healthcare, you can still go and do it. The NHS accepts that. And I think that's the only principle that one can do. One cannot prevent medical schemes from providing personal cover. And I think the issue here is also that private health schemes, in people funding private health schemes, they're not interfering with the NHI. I don't see how they will interfere with the NHI. The NHI would be separately funded and would work as a separate entity. I cannot see how the one would affect the other, and how keeping medical schemes going for private individuals who wish to fund that on top of their tax payments. I do not see how that would affect the principle of universal health coverage. So just to get back to the essential point, and I think this was something that popped up in a lot of the questions, is that the principle of the NHI is supported. But I wish to emphasize that if you have a badly functioning public health system and a badly functioning private health system, where the Department of Health is not doing its job, you cannot superimpose a payment system on these badly functioning elements and overnight expect wonders to happen. It's not going to happen. You have to sort out the problems first before you throw money at it. And I think that my slightly extensive answer there, I think should deal with a number of the comments that have come. And it's not a question of neoliberalism or anything like that. We are absolutely behind the principle of the NHI in universal health coverage. That is not the issue. And I will try to go through some of the questions which may not have been dealt with in my extensive answer now. I think one question, the comment was made that we are lobbying the private sector not to take part, but we're not lobbying that at all. The issue is for the private sector, really two things. One is the Department of Health must get around to regulating the private sector. It hasn't done so, and until it does so, the private sector health service is not going to work properly, and it's going to be too expensive. It's going to get more and more expensive. So we are not lobbying the private sector not to take part. But to get back to the issue of if consumers fund the NHI through their tax payments, we don't see why they can't pay privately for healthcare. And I think one of the things that people don't realize is that there is not going to be enough money to fund all health costs for everyone. The NHI is going to have to lay down a standard where it says up to this level we pay everything. If there's anything beyond that, we can't fund that. And that is going to be a very complicated mechanism to try and find where that level is. It's going to need a very big administrative component which continuously decides what the NHI can fund and what it can't fund. And that is going to have to change on a continuous basis. And I think just this one aspect underlines the complicated nature of implementing an NHI. You have to have a very efficient and effective administrative framework. If you don't have that, forget it, don't even try. And that is one of the issues which I think government has underestimated, is the degree to the difficulty in setting up an administrative framework which is effective and efficient. Now, we have no idea of what has been done, what is in the pipeline, But I just want to get back to this, the point that I think there's serious underestimation as to the difficulties of getting something like this up and running. The question was raised whether the state will be able to fund the NHI. Well, we don't know, because we don't know what the number is. Nobody knows. So the problem is that if you can't say what this thing is going to cost, how can you answer the question of whether the state will be able to fund it? And as I said, the principle will obviously have to be implemented by the NHI, whereby only certain services are covered. Other services you will have to pay for yourself, because there won't be enough money. But even that, we have no idea what that will be. So it's a question which neither I nor anybody else can answer. The question was raised about medical schemes, where people who are members of medical schemes run out of money because they become too expensive. Now, this is one of the effects of a lack of regulation by the Department of Health. It was one of the issues that was raised very clearly by the Health Market Inquiry, which said in no uncertain terms that the private sector has effectively become too expensive. And the reason for that is that it's not being regulated properly. So I think from government point of view, it's very dubious if they should come with the argument that the private sector is too expensive and will deal with it within the NHI. The fact that the private sector is so expensive is at least partly due to government's own failings through the Department of Health. So I think this point must be very clearly kept in mind. An issue, one of the members raised the issue of health costs twice and double dipping, but I didn't quite understand that. But it just gets back to the point of, if you as a citizen pay your taxes, and through those taxes the NHI is funded, then you as a citizen have dealt with your obligations to fund the NHI. If on top of that you have surplus money and you wish to go to a private scheme, we don't see why you cannot be allowed to. Trying to prevent people going to private schemes if they are tax compliant and have effectively funded the NHI, we don't see why that should there should be an attempt made to prohibit that. It's nonsensical. I think the issue that also was raised in a number of the questions is the assumption that once the NHI is implemented, there will be quality health care for everyone. And this is the problem that we have, that if you superimpose the NHI funding mechanism on a badly functioning public health system and a badly functioning private health system, it is not going to solve the problems overnight. And I keep on emphasizing this, but I think one cannot conflate the principle of the NHI with a practical situation on the ground at the moment. Just implementing the NHI, if it was implemented tomorrow, is not going to solve the problems. The problems have to be solved first. And I'm afraid that the Department of Health has not done its job here. And the only appeal I can make on behalf of the Foundation to members of Parliament is to raise these issues with the Department of Health and to ask them, what are you doing about it? The question of the consultation with the private sector, I think, the problem that I have here is that certain issues which appear in the NHI bill would really make me question whether any kind of consultation meaningful consultation has taken place. And if I can take this example of trying to prohibit private medical schemes. If I read Section 33 of the NHI Bill, it says, once national health insurance has been fully implemented as determined by the minister, medical schemes may only offer complementary cover to services not reimbursable by the fund. And I cannot see what the logic is behind that. I do not understand it. And once again, and if at the risk of repeating myself, if taxpayers pay for the NHI and they've effectively dealt with their debt to society, if I could put it that way, if they want to go and get private healthcare over and above that, I don't see it's their right to do so. You cannot limit that right because they've already paid their debt to society. A question was raised about the problems that we have in the private sector. But my answer to that is these issues were all dealt with in the health market inquiry, and it's over to the Department of Health to sort them out. They have to regulate the private sector properly. The issue was raised about health professionals prefer working in the private sector, and introducing the NHI will solve this. I think, again, I get back to the thing of if you are a health professional and you're working in a badly managed public health entity, and you see that you can make a lot more money in the private sector, which is badly regulated, and for that reason there's too much money floating around there, then I can see the attraction for some people to go over that. But the NHI bill, accepting or passing the NHI bill on its own, is not going to solve this problem. Once again, you have the existing problems of the public health system and the private health system, which have to be sorted out by the Department of Health.
I will have to give you 2 more minutes. I noticed that you really are not rounding up now.
Yeah, I'm just glancing through my questions. I think I've dealt with the basic issues, Chair. Unless you want me to deal with anything specific, just including. But I think the principles have been dealt with.
Yeah. Okay, Mr. Dawson, I think we should agree that there are certain areas that we will continue to engage us and the department. But if we have said to you, there's going to be a quality of health services the next day after the start, that's not what the bill is saying. The bill talks about progressive realization. So it means it's an incremental process. I think we tried to explain that. That is what is captured in the bill, not even by us. So I don't think there's anyone who has said there is going to be a quality the next day. So we would then want to bring this to a close, but we still want to give you 1 minute of wrapping up now that maybe we have looked at your notes to wrap up. We will still engage with you through the long document that you sent us, but please continue to engage with the department also on your issue that we feel strong about. But we should also leave this meeting agreeing that there has been reasonably good consultation in the country on this matter. And some of the institutions that have come before you have indicated their desire to have this and that looked into, because they were there during the inputs and they are still here now, just like you indicated, wanting to engage with us. Thank you very much. Your last comments?
Thank you, Chair. No, I think I've dealt with the basic issues in the presentation and in trying to answer the questions that were raised. And the essential point is just that the existing health system, both public and private, the problems there have to be sorted out before you implement the NHI bill. That's the essential message.
Okay, thank you very much. We will then leave this at that level and then bring this meeting to a close with you. And please feel free to continue to engage with us through our secretary. Ms. Machalamba, can you then give the new presenter access to sharing rights so that many members can only stretch and only 2 minutes, members, so that you can have a bit of a good lunch. Let's take this next presentation immediately after 2 minutes.
Thank you, Chair.
Honorable members, we now receive a presentation from Independent Community Pharmacy Association. They will indicate who they are, and then they will actually introduce their members. You have 45 minutes to make a presentation, after which honorable members will ask questions, clarity-seeking questions, and then you'll come back to reply on those questions or give your responses thereon. So your 45 minutes will start now after you have introduced yourself and then present. Thank you.
Good afternoon, Chairperson. Good afternoon, colleagues, honorable members of the committee, the Portfolio Committee on Health. My name is Khabu Komapi. I'm the chairperson of the Independent Community Pharmacy Association. With me today, I have got Mr. Mokholokolo Pasha, our NHA director within our organization. I've also got Nelson Mabusela, our young pharmacist, prospective pharmacy owner, who's currently the president of the SAPSIF, the South African Pharmaceutical Student Federation. And I also have Dr. Sham Mudli, the deputy chairperson of the ICPA. And with us, we also have Jackie Maimin, our CEO at ICPA. Chairperson, thank you for the opportunity that you have given us today to present to the Portfolio Committee our inputs with regard to the NHI bill. Now, we've made our submissions in the month of November 2019 on an invite by the committee to make inputs regarding the NHI bill. And we are happy today to come and explain our input and our submission that we made in the month of November 2019. Just to put perspective, it is important for us as ICPA to mention that we stated and indicated early on our unequivocal support of the NHI so that it can bring equality to healthcare provision in our country. And we believe that such a system will bring us prosperity and good health as a nation, with no one being left outside. Now, having indicated our unequivocal support, Chairperson and honorable committee members, it is important that we must highlight that we are making inputs in order to ensure the success or rather to contribute to the success of this particular program so that everyone within our country may be able to access health within the midst or the nearer to where they live, looking at the rural areas as well as the entirety of our nation. Now, it is important to mention to the committee that The building blocks of the NHI will determine its success, and it is important for us to indeed highlight areas of concern, which my colleagues that are here today will be seeking to highlight and touch on some of those concerns in terms of the foundation of the NHI and the governing principles around the program. So for me, as the chairperson of ICPA, I will also introduce it as an organization that is actually a non-profit organization. We represent about 1,221 pharmacies and about 3,500 pharmacists and 20,000 support staff within the metropolitan and urban as well as rural South Africa. And as ICPA, it's important for us to mention that we also work hand in hand with other stakeholders within our fraternity, the pharmaceutical sector and the medical sector at large. And it is also important, Chairperson, to indicate that we believe that through the NHI, we will see some of the resolutions of the ongoing problems that have been plaguing our private sector in terms of funding and regulation more broadly. We believe that if NHI can be promulgated well and the concept is thrashed well with all the inputs of all the stakeholders, we believe it can bring relief on some of the challenges that are currently plaguing the private sector, which I will not dwell too much on at this particular juncture. Now, we are looking at pulling all the resources within the pharmacy sector and in order to enlist them for the support of the NHI, and we expect continuous engagement from the committee with regards to the progress and changes that have been made with regards to NHI, indeed before the implementation thereof. We believe that any arising problems with regards to NHI must be attended before we can launch or even implement the NHI system or program. Now, it's important, Chairperson, to indicate also that we in the spirit of solidarity and recognition of the right of all citizens to health care, we will indeed commit all our resources to assist government to achieve this program, and sustainably so and equitably so. It is important for me, Chairperson, to mention that over and above the 1,221 pharmacies that have been indicated here, as a pharmacy at large, as a pharmacy community at large, we bring resources of about 3,600 outlets into the NHI program. That includes other pharmacy outlets that have not been enlisted within the ICPA, but they are with our other sister organizations. We bring for you, Chairperson, a support of 42,000 personnel over and above the pharmacies that we are bringing forth for NHI to leverage upon. And we believe that in the beginning of this NHI, which is now, it is important to thrash out all these possible resources and really scope them well, particularly looking at pharmacies being primary healthcare outlets, if I may put it that way. It is important to highlight that these resources, if leveraged well, they will bring a good contribution to the success of the NHI program. So, Chairperson, just before I'm going to be handing over to my colleagues with me, it is prudent for me to mention also that within the current health sector space, before the implementation of the NHI, it is key for us to mention that there are contributions that we continue to make, even with the restricted or the limited resources that we may be exposed to. It is important to mention that we contributed immensely to the testing program in the beginning of the pandemic in our country in the year 2020, which is last year. In collaboration with the Solidarity Fund, we delivered quite a huge number of tests to assist a national department with regards to the pandemic, the COVID-19 pandemic. It is also important, Chairperson, to mention that in the current vaccine rollout, we continue to contribute immensely as the pharmacy sector. The numbers are speaking for themselves in terms of how many vaccines have been really jabbed into the arms of our people from the beginning of the rollout. Now, it is important for us to indeed take this opportunity to highlight the importance of pharmacy in our country and particularly in our health sector. That pharmacy needs to be given a voice, needs to be given space. It can deliver quite substantially to the well-being of the nation. And it is important, Chairperson, to indicate also that through our advocacy engagements with the department, where we have managed to attend to some of the challenges that we are faced at the private sector. Also, not to exclude the issue of the medical aids, we are in continuous engagement with the regulator with regards to some of the grievances that are arising from that side in terms of inadequate regulation, if I might politely put it that way, Chairperson. We believe the NHI can also be a solution to those non-regulation or insufficient regulation of some of the sectors of our health sector. Let me, in the interest of time, Chairperson, take this opportunity to welcome my colleague, Mr. Mkhologolo Pasha, who will be taking us through the pertinent points that we have highlighted and contributed to on the NHI bill itself. He will be telling the committee as well as yourself, Chairperson, how we suggest that the NHI can be looked or tweaked to accommodate other stakeholders, in this case, the pharmacy sector, in the interest of our population. Let me pause there, Chairperson. Thank you very much.
Thank you very much, Ndade Komabe, our Chairperson. Chair and members of the Portfolio Committee, I would like to also echo my word of gratitude for the time that you have given to us as ICPA to raise few of the issues that are contained in our said submission that our Chairperson talked to. Let me right away get into the issues, Jackie. The NHI bill, I just want to first start with the definitions. There's few definitions in there that we wish to talk to. The first one is the fact that pharmacies provide comprehensive healthcare services as defined in the NHI bill through the provision of pharmaceutical care. Pharmaceutical care is a patient-centered, outcome-oriented pharmacy practice that requires the pharmacist to work in concert with the patient and the patient's other healthcare providers to promote health, to prevent disease, to assess, monitor, initiate, and modify medication use, to ensure that drug therapy regimens are safe and effective. The goal of pharmaceutical care is to optimize the patient's health-related quality of life and achieve positive clinical outcomes within realistic economic expenditures. I think for us, it was important for us to expand a bit on this pharmaceutical healthcare because it pertains to the work we do as pharmacists, particularly community pharmacists, when it comes to the as part of the healthcare delivery system. And of course, most importantly, the great health outcomes that come from the intervention or our partake in the process of taking care of the people that we take care of. Jackie? I just want to also talk to the fact that the primary health care currently is defined in the NHI bill to say that it is the means of addressing the main health problems in the community through providing promotive, preventative, curative, and rehabilitation services. And A, in the is the first level of contact of individuals, the family and community with the national health system, bringing healthcare as close as possible to where people live and work, and constitutes the first element of a continuing healthcare process. I think for us, the main reason why we indicate and want to overemphasize, if we may, the definition of the primary healthcare is because it talks to us as community pharmacists. Because as community pharmacists, we are the first level of contact for healthcare related matters. We know that, for example, in the current setting in the public sector, we are not, pharmacy is the last point of call when one goes to a hospital, for example, or goes to a clinic, because that's where they end and pick up the medicine and go home. But what we know is that in the private health system today, we are the first point of call. People come first to us because, number one, we are trustworthy. We are accessible. We know for a fact that community pharmacies open for long hours. In many occasions, when any health or all health establishments are closed, community pharmacies are the ones that remains open inside the communities, and therefore they become the first point of call for those communities. And that is very important for us, why we have the community pharmacies as part of that primary health care at that first point of call. We know for a fact that the bill currently indicates clearly that members of the public will enter the NHI through the primary health care points of service. Now, we believe that then community pharmacies should be included in that first point of call, or in that first point of entry into the NHI, because that's what the bill is saying. It says that the first point of call will be through primary healthcare services, and primary healthcare services are adequately provided by community pharmacies in today's date. Let's check in. I just want to highlight some of the points or services that we give as community pharmacists on an everyday basis. And I want to go specifically on some of the services that we render, which are not very conspicuous to many people, but are actually core to what we do. And therefore, in the next about 4 slides, we are going to talk to a few of them. I will not go through all of them, but I will just highlight those that we believe that they don't receive the highlights that we do as first point of call for the communities that we serve. Can we get to the next one, Jackie? On this slide, I want to indicate or highlight specifically on the vaccination programs, because community pharmacists have been by far the providers of vaccinations in the country, even before the COVID-19 pandemic. If one looks at all the influenza vaccinations that have happened in the past years, by far the majority of those happened within community pharmacies. So it is not even a surprise that community pharmacists today, when the issue of vaccinations for COVID-19 came in, we raised our hands as the natural people who have been handling vaccinations all these times. We will know that most of the vaccines right now are already kept between 2 and 8 degrees, which is the temperature that we are really accustomed to use, because most influenza vaccinations fall in that temperature category. So it is natural that we are in helping and playing a very big role in the COVID-19 vaccinations today, even though, of course, there are other newcomers who took over some of the services that is very core to us. I want to also indicate PrEP and PEP. So PrEP is pre-exposure initiation of ART, antiretroviral therapy. And PEP is post-exposure. Now, I want to indicate that as we speak right now, our members of ICPA, community pharmacists out there, are continuing to train in upskilling themselves to be able to be providers of this very service. We are initiating and dispensing ARTs right now with, or should I say, in line with the scope of practice that Pharmacy Council is giving to us to do, because we have approached National Health to allow us to do this work already, and we have, and it is work that National Health has actually accepted and welcomed us with both hands for us to be able to help with that. So I wanted to just highlight these specific ones because over and above other things that people know that they do blood glucose testing in pharmacies, there is much more that we do. And all these are first point of call. We are there in the communities. We are there in literally, as our chair indicated, that our locations, we are in Ramashashane, we are in Hangkwana, we are in Kanyamazane, we are in Mamelodi, we are in center of Johannesburg, we are everywhere in the suburb. So in terms of access, we believe that we are the most relevant people to provide primary healthcare and to be the first point of call for NHI. And therefore, our prominent inclusion as such becomes very important. Next one. I think let's move to the next one again. Yes, you know, for completeness, I also want to indicate one of the roles that we play, which is this one, which is the palliative care that most pharmacists in communities play. You know, the issue of palliative care is a very important part that pharmacists in the communities play, because most of the time these patients are known to them very intimately, and therefore they play a very important role in that section of their lives, and the support, such as the hiring of nebulizers, oxygen concentrators. You know today, obviously some of these functions that we do normally on our everyday basis, such as oxygen concentrator hire and similar, is done by Tom, Dick, and Harry out there, but it is a specialty that most of our pharmacists are trained in, and they support the communities they live with in that. So we recommend, therefore, in essence, the inclusion of pharmacists in the definition of primary healthcare specifically, so that we can remove any possible or future ambiguities that could arrive in terms of the role that community pharmacists, in particular, the independent community pharmacists, play in the communities. Next one, Jackie. So I just want to indicate here or highlight the B on primary health care to say that primary health care represented by primary health care professionals, including but not limited to the general practitioner, professional nurse, and we add that pharmacist in there because we believe that it is key for us to include or to add that pharmacist in there as part of that list. And I want to indicate it more so because the allied health professional does not include a pharmacist. A lot of people believe that the word and allied health professionals include pharmacists. It doesn't. And I will expand a bit on this one to say that you will realize that Health Professions Council registers general practitioners, dentists, dental practitioners, and at the end, in there, they have what they call allied health professionals. Now, outside of that regulatory body, there are two other bodies, which is the South African Pharmacy Council and South African Nursing Council. These specifically register nurses and pharmacists. And therefore, when we specify health professionals, we have to specifically go through that. If you go to general practitioners, you go to professional nurse, you go to pharmacists, and then you can have the allied health professionals, because there are different regulatory bodies, in particular for the professional nurse and the pharmacist. And hence we are asking for that inclusion of the pharmacists, because we are not included in the allied health professional. And when we are doing a document like a NHI bill, you want completeness, you don't want ambiguity, so that when you're writing regulations, it's clear that what you mean when you say allied health professionals and pharmacists, because the lawmakers will go again to look at the definition of what is allied health professional, and in there they will not find the pharmacists, and that's where then the confusion can happen. And for completeness, we therefore request for that. Thank you, Jackie. We believe that we are currently serving the asylum seekers, illegal foreigners, and we know very well that government does not have a limitless pot of resources. But we thought that it could be strategic or helpful if we could not, for example, in the NHI environment, cease the services that we are giving to these people, because in the current state, we will have specific, in the current state of the NHI bill, we will have very limited work that we can do or service that we can give to these people, the asylum seekers or illegal foreigners. So we therefore are asking that if Portfolio Committee or Parliament can look at how to ensure that we continue to give the service that we are giving, instead of excluding these South African inhabitants. In terms of the establishment of the fund, there is a key point that we wanted to highlight in there, which is 10.1, specifically on number K there, where it says, to achieve the purpose of the Act, the fund must ensure that healthcare providers, health establishment and suppliers are paid in accordance with quality and value of the service provided at every level of care. I think for us here, it is very important to indicate that the quality measures that will apply to pharmacies are not specified clearly. And it's important to stipulate that the pharmacists know what their services will be measured against and to enable compliance. And we trust that this, perhaps, if not clarified now in the bill, they can be clarified in the regulations. On the registrations of users, specifically two issues. The fund may enter into a contract for the procurement and supply of specific healthcare services, medicines, health goods, and health-related products with an accredited health care service provider, health establishment or supplier must negotiate the lowest price for goods and healthcare services without compromising the interests of users or violating the provisions of this Act or any applicable law. I think for us here, we just want to indicate that Parliament should also realize or just pay cognizance to the fact that for us as independent community pharmacists, we believe that we are already running establishments that are heavily regulated, much more than any other professional in the health sector. Parliament will remember that we are regulated through single exit price for medicines. All medicines that we sell are regulated by single exit price, and also the dispensing fee, the fee we charge over the single exit price or our profit, it is also legislated. Portfolio Committee give legislated fees that we may charge to the public out there. And so we are appealing to Parliament to remember that part in negotiating this lowest possible price of goods. So we are almost saying that currently we are already having shortage of pharmacies out there, particularly independent pharmacies. We will employ on Parliament to look at enabling measures that will ensure that more pharmacies are opened in the communities that we serve, the communities that don't have these services, because there's many communities which do not have the luxury that me, for example, in Mamelodi has, because Mamelodi, for example, has what, about 10, 11 pharmacies as a community. But when you go to Ramashashan, you go to Moletlane, I mean, you don't even have one pharmacist in that area. We want to ensure that there are more young pharmacists who go to Amoletlane and open a pharmacy in there, and in a way, bring the pharmaceutical service to the people. Let Gwagwa Dlamini have the same access that I have in Mamelodi or in Pretoria East or North, and where I am, so that the service is equitable to all the people of the country. Jackie? With regard to the establishment of the advisory committees, there is one specific one where we are defining, where it is indicated that such a benefits advisory committee should or must consist of persons with technical expertise in medicine, public health, and health economics. Our interest is in the definition of medicine as it is defined by the Act 101 of 1965. And we are requesting that in choosing or finding this technical expertise in medicine, it should be indicated that there is no better expert on medicine than a pharmacist, as we know. And therefore, if it could be expanded already here at this level of the bill, or if it could be borne in mind for the regulations to ensure that this person with technical expertise in medicine has to be a pharmacist, because there are people who have, I mean, we do have people with some degree, of course, in medicine, but it is kind of wide ranging kind of a expertise than a technical expertise, which we believe only resides with a pharmacist. So we employ on Parliament to ensure that it is actually a pharmacist. On the matter of the Office of Health Product Procurement, 38, it says the Office of Health Product Procurement must determine the selection of health-related products to be procured, A, and B, develop a national health products list. So we submit at this point that the selection of this health related product to be procured should include the cups, because we believe that the cups in the area, they are more of a, if I may say, with the health issues that exist in that area. And we do not see the consultation of the cups being mentioned in there. One will remember that WHO in years past used to overemphasize the use of, or the not the use, but the establishment of the pharmacy therapeutics committees in hospitals and provincial therapeutics committees. And the main aim of that was to ensure that there are what we are raising is being addressed. I see my time is going long. Let me try and go faster, Jackie. In accreditation of service providers, in order to be accredited by the fund, a healthcare provider or establishment in the case must be in a possession or produce. I think let me just talk to this point because it is in our submission already. We just want to indicate that for us as pharmacies or independent, actually all pharmacies, independent or corporate, we are already registered. Perhaps the only health establishments that are actually regularly inspected by South African Pharmacy Council, our regulatory body, and therefore the need to also have Office of Health Standards Council to continue to do that might also be overbearing, and we request that OHSC may actually delegate this to Pharmacy Council because it is already happening, and we believe that they are already having expertise in there, as they have done it already for many years in case of pharmacies, and therefore they can do it, however, to other health professionals who are not getting that. Jackie? So with regard to the information platform of the fund, I think we just want to submit that the payment mechanisms and rates for personal health care services must include input from all stakeholders, including representatives of the pharmaceutical sector. This cannot be a unilateral process without the set inputs that will inform the fund on the operational challenges and evolving landscape that must be considered when making decisions. We just believe that personal pharmacies are important to play a role in that. And with regard to the payment of healthcare providers, a cap, we just want to indicate that in a cap, you will ordinarily find a GP, a nurse, a dentist, and a pharmacy. And we want to indicate that these other three health professionals that we work with it is easy for them to have a capitation model. But however, because as a pharmacy, we provide a service and a commodity, meaning the medicine as a commodity, it becomes difficult for a capitation model for that. And therefore we request a bit of a hybrid model of capitation and fee for service when it comes to pharmacy, because of the fact that medicines are of different pricing, as we know. Thank you. Jackie? Definitions of healthcare worker and healthcare provider. I think I talked to this a bit in terms of when I was explaining the fact that the pharmacist's role or scope of practice has improved. It's no longer that chemist that used to be known. We are doing much more things today, and indeed in years to come, there's more that are going to be done by pharmacists because of the training that we receive. Jackie? We are asking that in the amendment of Act 101 of 1965, we include the pharmacist in there, particularly when it comes to the prescriber, because we prescribe medicines on everyday basis as pharmacists. I want to just quickly say that when a person who comes into a pharmacy and explain the flu symptoms or a headache symptoms or show me their hand that is injured, I look at it, make a decision, and prescribe something for the person to take. Albeit it's Schedule 1 and 2, but that decision is still prescription. That's why it's still prescribing. That's why we have to be included in there as we are amending Act 101 to include the pharmacist on the authorized prescriber. Thank you, Jackie.
You have 6 minutes to go.
Okay.
I don't know how much.
I think I will stop it there. Thank you, Chair. And I will give the pharmacist student, Nelson Mabusela, to continue.
The whole presentation has only 6 minutes to go.
Yes, Chair, he will take 2 minutes, and then our Deputy Chair will take 4 minutes, and 6 minutes is done. Thank you, Chair.
Thank you.
Thank you very much, ladies and gents. The name is Nelson Mabusela. I am the sitting president of the South African Pharmaceutical Students Federation, which is a body that represents professional challenges for all students in the country through all 9 universities. And this is accounts for over 3,000 students. Chairperson and honorable members, I think the point of departure here as students is that we support the call for universal health coverage and the NHI, the instrument. However, as students, much as we support that, we just have a few things that we feel that would be doing an injustice to ourselves as parliament, as leaders in respective formations, and to the nation at large. And central to these challenges is the influence of corporate in the practice of pharmacy in South Africa. Chairperson, you would find a situation where even medical aids will tell you that through your establishment as Nelson Mabusela's pharmacy, they'll force a patient to then say, this particular service provider is not on our list. Go to this particular service provider who may be way away from where you are. And when you look at the socioeconomic backgrounds and given the imbalances of the past, this can compromise the very governing principle of NHI, which is access. And through that, the influence of this alleged collusion of big corporates, what President Pasha has indicated to as there's currently the shortage of pharmacists in all sectors of the community. Previously, government has resorted to taking a resolution to afford lay ownership to non-pharmacists to own pharmacies, with a primary responsibility to increase pharmaceutical services to everybody in the country. But what we have seen is concentrations of pharmacists in big cities and towns, while the very previous communities are still remain isolated. And secondly to it is the continuous unemployment of pharmacists. And this has only kicked in following the provision of this lay ownership. Therefore, as students were saying that in order to achieve this absolute or a true definition of the universal health coverage, let us reverse all those things, the lay ownership of pharmacies, and allow at least pharmacists to own pharmacies and see if we'll not address this particular societal challenge. And with that being said, Chair, I want to indicate that the support of SAPSEF, which is the Pharmaceutical Federation, to ICPA is not a sycophantic ramble. It is evidence-based, for example, on situations when following this growing unemployment as an influence of corporate, ICPA has actually came in very significantly to the call of students to then say, employ our young professionals. And following the outbreak of this pandemic last year, a lot of these big corporates never wanted to take students in for retail experience training. But the ICPA has been very central, including now, even in the curriculum reviewal and the improving of pharmacy scope, as Moholo Pasha has indicated. ICPA has been very central, and for that, I would like to say, to reiterate the call to say, include the pharmacy definitions, the pharmacy in the key definitions of the NHI bill and the Act 101 of 1965. And in conclusion, Chair, Dr. Domo and honorable members, as Nelson Mabusela and the entire population, student population, we are saying to you that at least hold hands with us in ensuring that we reverse this call that was made, this resolution that was made to have pharmacy ownership to non-pharmacists. Because out of it, the only definition that has been made was that capital is only loyal to profit and not to service delivery. But further to that, involve the ICPA in all strategic objectives and programs that are taken in implementing NHI with regards to pharmaceutical services. Thank you very much, and over to you.
Dr. Mutlu?
Chairperson, can I still indulge you with another 3 minutes?
Go ahead, Dr. Mutlu.
Thank you. So thank you very much to Chairperson and the Portfolio Committee for allowing this. We certainly see the National Health Insurance as a mechanism for South Africa to quickly advance our goals to achieve universal health coverage and to join the ranks of Japan, France, Germany, and of recent Indonesia, Thailand, and Turkey. The Brazilian model, Chairperson, is a good example of pharmacists participating through the Populara Pharmacy of Brazil, where not only are pharmacists involved as the touch points for primary healthcare, they also
the committee has problems when you make conclusions that you're not having a slide when you just talk. We do have even the previous presenter. What are you talking about? Where is that showing in the slides?
Chairperson, I didn't do the slides. I'll send you the document.
read that document for us, because we can't engage with the things that you are saying without us looking at what are you saying.
I'll ask Jackie to send you that document, Chairperson. It's just the concluding remarks. Everything else you've seen on the slides already.
Yeah.
Is that okay? Can I go?
Go on, yes.
Okay, so as I said, Chairperson, the Brazilian model is a good example to use, where the pharmacists are not only the touch points for primary care, but they also provided millions of registrations for NHI. And I would like the portfolio committee to take note of that. When you're bringing on new people onto the NHI, we're happy to help you with that. Despite the development of a stronger and clearer policy focus on the role and potential of both community pharmacists and pharmacies, at council level and at ICPA, and some innovative local developments, what stands out is the relative lack of movement on funding, commissioning of services, or contractual frameworks to support the delivery of direct patient services. Community pharmacy is subject to a particularly complex set of scheme rules which appear to support the status quo and innovative upscaling of services. More and more community pharmacists are employed at commercial organizations for whom business imperatives are critical. Current public health initiatives in South Africa seem to be supportive and in line with the scope of the pharmacy team. Many well-documented initiatives relieve pressure points at primary care, example, the CCMDD project that we are doing, provision of sexual health, baby immunization, and the flu campaign that was already discussed. What this—
We'll end it at that point then. We'll end it at that point. You can't have so many paragraphs that you can't read, and it's only you who's got access. We don't allow that.
Agreed, Chairperson. I agree with you.
So we stop it at that, and therefore let's allow members to ask questions. Whatever you say must be projected here, and if you don't have it, then let's leave it at that. Okay. The following members have indicated their desire to engage the presentation, but it would be important to indicate why you think you are better placed than nurses in providing primary health care. Some of us will think of the contrary, because nurses are far more in abundance than you are. There are many nurses in the health sector, both private and public, than pharmacists. Therefore, and also they do have a training in providing primary health care. Now, you will have to educate us that your scope of practice, among other things, gives you that space to examine patients and provide clinical evidence-based clinical care. I would really welcome you to say you're part of a team, a strong team, but to put yourself ahead of nurses in the provision of primary health care, it's something that you need to educate me about that. Can I therefore request the following members to engage with you? The following have shown their desire. Is Honorable Sokacha, first one, followed by Honorable Dr. Harvard. The third one is Honorable Mahlengwa. I haven't checked, honorable members, the next one. I just noticed that Honorable Gala says she has a problem with connectivity. So the next one, yes. Dr. Jacobs, you are number 4.
Nyai.
If Honorable Munyai, you will be number 5. Any other contributors in that order? Starting with Sokacha, Harvard, Mahlengwa, Jacobs, and Munyai, 5. Start, Honorable Member.
Thank you very much, Honorable Chairperson. Let me welcome the presentation. Chair, I've got few clarity-seeking questions. My first question, Chair, is more or less linked to what we have said in your remarks. I'm not too clear about the points advanced by ICPA in slide number 10 and slide number 11 of the presentation. is ICPA recommending that the primary health model they propose is that pharmacies should be made the only first point of call for patients under the NHI? Did I understand this statement correctly? May I please get clarity on that? Then, Honorable Chairperson, my second question is that ICPA has been at pains to explain the importance and relevance of members of ICPA. Why are you under the impression that the pharmacy sector is not considered as important? What in the bill indicates that this category of health care professionals is trivial? Can I just check from my notes, Chair, if I do have another question? I think that's all, Chair, that now I can ask. Thank you.
Thank you, Chairs. I have two questions. Can I get some understanding of how ICPA member pharmacies hope to support advance the intentions of the proposed provisions of the NHI bill? Also, what proportion of ICPA member pharmacies have presence in the urban, metropolitan, and rural areas? Second question, can I please be assisted to understand this? Is the South African Pharmacy Council not consisting of members who have a vested interests in the pharmacy profession? I'm asking this because ICPA seems to suggest an independent institution such as the Office of Health Standards Compliance must be removed from pharmacies, and the NHI bill must allow the pharmacy profession to regulate itself. Am I understanding ICPA's presentation correctly on this point? Thank you.
Thank you, Chairperson, and thank you to the presenters. Now, we are all aware that we have had
Before you, Dr. Jacobs,
sorry, yes, you're correct, Chair. My apologies.
Yeah, Mahlengwa.
Thank you, Chairperson. Apology accepted, Kenny. First of all, let me welcome the presentation from ICPA. I have just two questions from them. The association complained that the bill does not fully address concern for the refugees and other foreigners. But we know that the NHI will be paid for by the people of South Africa, and that the NHI is for the people of South Africa. Should we hold the NHI bill stage simply because there are concerns about foreigners? Will this parliament be acting rationally if it does so? Thank you.
Yes, your turn now, Dr. Jacobs.
Yes, thank you, Chairperson, and thank you, Mahlengwa, for accepting my apology. Appreciate it. Chair, on the presentation, we've had so many presentations by the pharmacists and pharmacy associations. I am really concerned about where this is going in terms of the proposals which are made by the pharmacists. And you've actually spoken to that as it's as if it seems to be the beginning of all consultations must be with the pharmacists. And my concern is about scope of practice of the many different healthcare providers and how our training puts us in a particular bracket, and our qualification at the end of the day puts us, whether it's a B farm or an MBCHB or B curve or whatever, it puts you within a particular scope of practice that is defined within the rules of the HPCSA. I do understand that groups would want to advance themselves within the NHI bill and would want them, each group would want themselves to be mentioned in particular by their profession within the bill, but it does raise with me, it does not sit well with me. There's a personal advancement of particular groups. Now, having said that, noting ICPA sentiment and proposal to include pharmacists in some of the definitions in the legislation, such as the Medicines and Related Substances Act, I'm bringing that to bear here with that. However, ICPA should note that some of the proposed amendments that they are making may not necessarily relate to the objects of the NHI bill. So does the ICPA wish to have the Medicines and Related Substances Act amended to incorporate their proposals? And then we also want to commend them for their proposals that they would assist our country with service provision with regards to the COVID-19 management. Question is whether they had shared their views with others in the private sector, and you know, if we can also be informed on those views, because those seem to be very important, especially at this time with our pandemic. Thank you, Chair.
Thank you, Honorable Chair. My first question, Honorable Chair, is as follows. Why does the ICPA interpret that the bill stops you from employing your own trade and profession in terms of Section 4 of the bill? Are you concerned about who will pay you when you consult with customers or patients that are not covered in terms of Section 4 of the bill? According to the ICPA, only pharmacies should own pharmacies. Given the limited number of these professionals, as you have outlined, would reversing the current arrangement where non-pharmacists own pharmacies will not be detrimental to our population if done in the NHI environment? Does the ICPA not seek to value the broadening of the pharmaceutical access to non-pharmacies, provided that the management of pharmacies still remains in the responsibility of the qualified pharmacists? Can I get some clarity on this with regard to this, please? May I also please, Honorable Chair, I note that ICPA sentiment and a proposal to include pharmacies in some definition provided for in the legislations, such as the Medicines and Related Substances Act. However, ICPA should note that some of the proposed amendments that they are making may not necessarily relate to the object of the NHI bill. Does ICPA wish to have the Medicine and Related Substance Act amended to incorporate the proposal? Lastly, Honorable Chair, I agree with my good sir Mabusela that the pharmacy are really dominated on the urban area. Isn't that reason enough to justify the support of the NHI as a mechanism to achieve the universal health coverage? Indeed, it is true that you said again, the big corporates attempt to influence the pharmacies. If this indeed is happening, I will need your confirmation. It will be indeed unethical if I hear you correctly. Thank you.
I think it was Dr. Honorable Munyai, the last one.
Yeah, I'm not a doctor, Mr. Munyai. Thank you. I'm not sure of them. Thank
you.
Yes, Jay, it was the last one.
Oh, it was the last one. Okay, sorry for that, Honorable Munyai. I need to be educated by this team because one actually I think was said by Honorable Dr. Jacobs. We have had a presentation by Pharmacy Council. Now, Pharmacy Council is an overriding body of all pharmacists in South Africa, whether in public or private, whether in rural or urban. And therefore, we would wish that we do not dissect very much, but we would like to listen to everybody as we have listened to yourself. Please assist me in understanding your role in the fight on the antimicrobial resistance, which seems to be a challenge not affecting South Africa, but the whole world. Your stewardship to mitigate against the antimicrobial resistance, it would be important to hear that. But again, it's to amplify that point of you providing a service probably adequately well, but I think you should just be conservative and not put it at the level that is much more above that of a nurse. I wanted just to check that part in your area. But I think I also want to ask one other question on this matter regarding your presentation. You made mention that the IPA keeps track on the extent to which they are prescribing. It will be contributing to health outcomes. Are you in this regard having linkages with the district health information system, which among other things, by the way, is doing that? I would also like to just check with yourself in terms of whether you were familiar or we have seen what the Pharmacy Council has presented to this portfolio committee of Parliament with regards to the NHI processes. Thanks.
Chair, if I may, not in here, if I can ask a follow-up question, please, or few follow-up questions.
Okay, let's do that now because I'm not going to allow after they have replied other follow-up questions. Yes, let's do that now.
I would appreciate it, Honorable Chair.
Chair, I just want to, yeah, let me, you've just taken me, set me back a bit, but let me go there. I want to speak about payment strategies, which are referred to in slides 25 and 26, and want to know from the group whether they are strongly married to those proposals being legislated. Will they concur that those can be contained in the regulations? And would they concede that a lowest price, which is possible, takes into consideration sustainability? We need our service providers to be in a position to serve the public. If they can please comment on that. And then in terms of medical legal claims for pharmacists, what type of, and again, in medical legal claims that pharmacists faced in the delivery of personal healthcare services, and how do they propose it should be mitigated under the NHI? Thank you, Chair.
Thank you, Honorable Chair.
Yeah.
My last, my follow-up question is that on slide 24, I note that our proposal, note that the proposal that any additional determination by Office of Health Standards Compliance to be delegated to the Pharmacy Council to improve efficiency. As your regulator engage the OHSC to advance this proposal, or are you suggesting that this arrangement must be legislated through the NHI bill? What is the OHSC as other option that it may wish to regulate the function to? And the other question that I want to put forward, Honorable Chair, is the
last one. Yeah.
Oh, okay, the last one.
That will be the last one we are putting through now. Yeah.
Okay. What type and the trends in medical legal claims pharmacists face in their delivery of personal health care services, and how do they propose it is mitigated under NHI? Thank you.
Pharmacy Council is 5:02 now. You will have to finish at 2:10, not longer than that. 2:10, you are done. Thank you.
Thank you, Chairperson, and indeed all the committee members for the questions. We will move to answer the questions. It may not be as orderly as the questions were asked, but we will try and answer all the questions as they were asked by honorable members. I'll give this opportunity to Mr. Pasha to kick off the answers. Just indicate which question and so that you can answer, then we can relate. Thank you, Chairperson.
Thank you, Ndadeko Mapi, our chair and the chairperson of the portfolio committee. I think on the onset, I would like to clarify a very important point. In no terms do we believe that us as pharmacists are better than any other health professional. I think I want to indicate that part because I think it was misconstrued. Neither are we saying that with regard to primary health care, we are better than any other health professional. We, in fact, are proponents of not putting one healthcare professional on top of the other, because we strongly believe that healthcare professionals work in concert. What makes us to emphasize, in fact, what makes us to overemphasize the issue of the pharmacists is our realization of the lack of mentioning of the pharmacists in the bill as it stands. And therefore, we are merely highlighting to Parliament that, have you realized that you have missed pharmacists in this? And that's why we are indicating the role that pharmacists play in primary health care. This is to say to Parliament, include the pharmacists in case it was a mistake of overlooking them. And I think that's where we are on, not saying that pharmacists are better than anyone and they can do any job better than anyone with regard to primary health care services. No, we are not saying we are better than anyone. We are saying that we play a very important role in primary health care, which might have been overlooked and has resulted in the lack or the non-mentioning of pharmacists in these different places. And hence, even on the legislation amendments that we are asking that you include the pharmacists there, because we are then highlighted the role they play in those parts, like the part that I've mentioned with regard to prescribing, to say that they actually do. The aim is just to give more clarity to Parliament. It is not to say that pharmacists can prescribe better or anything of that sort, but it's just to highlight that pharmacists do prescribe, and therefore they should indeed be there. I think that's very important that we are saying that. We are not saying that we should be put above any person, but we believe that we should be included in those sections. Now, another point was mentioned on the sorry, on the refugees at all. We are not, this is not a deal breaker, and therefore we are not saying that NHI must be stopped because of this point. And if you remember our call that we made to the nation when the minister came to address our conference, one of the main things we said during that call to the country, we said to the country cannot wait any longer for NHI. We believe it has to come out. It has to be implemented as soon as possible. So any impediment, like a matter like this one, cannot be allowed. We are not saying that things must be stopped because of that. So please, we are not having any personal advancements for pharmacists that we are trying to put forward. No, we are just highlighting the lack of mentioning in the bill. I will give my colleagues to handle other matters that are there. Perhaps I can talk a bit on that OHSC matter. I think all what we are saying is that it might be counterproductive to want to have a monitor of a monitor, or to have two monitors to monitor a particular service. And hence we are saying using OHC and Pharmacy Council might be trying to have two monitors doing the same thing, or one monitor monitoring another monitor. And that's the advice that we are really giving to Parliament, to say that there is a lot of work that is being done by the regulatory body. And we are suggesting that the two can have a memorandum of understanding or similar to ensure that they don't duplicate and they don't become also onerous to the profession. Thank you.
Dr. Moodley, please go ahead.
Thank you, Chair. Chairperson, I'm going to take two questions that I've been given. One is on the ownership issue of pharmacy. So if you remember, Chairperson, in 1997, in Parliament, there was a motivation to open ownership to lay persons. And the idea was to take community pharmacy into outlying areas. A few published papers recently in 2020, 2019 suggested that that has failed. What did happen was that we had the corporate world come in, and where there were pharmacies already, new licenses were issued to corporates, and those pharmacies that existed owned by individuals had to close because of the nature of the competition. That's the first issue. So we did not achieve what we needed to do in 1997, and therefore we're asking that that regulation or that law needs to go back and be re-evaluated as to whether we need to change that and to find another methodology. The second issue, Chairperson, is the question on the best possible price to the market. And we are in total agreement that that should actually happen. So the first equation is the single exit price of the medicines. We do believe that more can be done to bring down the price of medicines. There's probably about a 15% margin that's still there somewhere in the system, that better regulations, or remember we passed this regulation in 2004 and it has only been evaluated now. We need to go back and re-evaluate to see how that can be changed a little bit more to get a bit more out of the system in terms of generic substitution, for example. Then remember that the other part of the equation is the services that pharmacists provide, and that is regulated by the pricing committee as well. So we have a price that the pricing committee has evaluated and determined, and that went up to the Constitutional Court. The court indicated that that fee needed to be a reasonable fee. And that's what the pricing committee put out. If you put out a reasonable fee, and then you have a challenge of corporatization of that fee, in other words, who can provide that service at a much lower cost because of their own infrastructure back end. That is the issue of ownership of the drug, ownership of the supply chain. In other words, they own the drug, they own the supply chain, and they own the service. Certainly you're going to get a better price on that marketplace. So it transformed that market into what was a pharmacy market into a corporate market. And therefore, the pricing regulation in itself is a kind of failure in that we didn't take care of all of these little equations that has created the problem of pricing in the country. And we are with you on this. If that is the best price we can get in the market in terms of an open market, it's a different story, but we in a regulated market. So if you have a determination of what the petrol price is, we can't have a market that competes for petrol. We need to make sure that that market stays in that same way. I hope that answers the question, Chair.
Thank you, Dr. Mutli. Ms. Maimin, can you take the question from Honorable Sokacha with regards to the nurses as well, and any other question you may? Jackie?
Certainly. Good afternoon to everybody, and I'll be very quick. So I think Mr. Pasha also indicated that we certainly don't see pharmacy as the only first port of call. In fact, in the private sector, pharmacies work in very close relations with nurses. Most of us have primary healthcare clinics that are run by a professional nurse. I think the emphasis is that we just want to be included, and that very often we have got 3,500 pharmacies out there that are already the first point of care, and that we can add these services to the NHI infrastructure. There was also a question about how many of our members are in underserviced or rural areas, and the answer to that was 40%. There was a question around scope of practice, and the reason we are asking that pharmacists be included in some of these definitions, especially authorized prescriber, is because it currently drastically limits our scope of practice. Because we've been left out of certain definitions, we find it incredibly difficult to be able to practice our scope of practice efficiently. Antimicrobial resistance, I think Dr. Tloma was asking that question. And I think this comes to the point where, certainly in the private sector, if somebody goes to the doctor and they have a cold, they want an antibiotic. And we know that that is not the right way to do it. So what we're saying is allow them to come into pharmacy, see the professional nurse in the pharmacy, chat to the pharmacist. We would give over-the-counter care, or what we call pharmacist-initiated therapy, which is no antibiotics for viral infections. And we can greatly contribute to antimicrobial stewardship in that we could do the public education on infection control. We would limit exposure to antibiotics where it's not necessary. And as we've already indicated, pharmacists are out there vaccinating, so we can get the flu vaccines in and reduce these infections and secondary infections. I think that was all. Oh, the health outcomes monitoring. There was a question there, do we link into the district reporting systems? No. Part of the different phases of dispensing within our scope of practice is to monitor therapeutic outcomes. We call it treating to target. So if we receive a prescription for an antihypertensive, we will monitor that patient over the next few months to ensure that they are reaching target with regards to their blood pressure. Remember, these patients see pharmacists at least once a month, these chronic patients. They will only see their doctor twice a year and their specialist maybe once a year. Thank you, Mr. Chair.
Just to wrap up, honorable committee members and chairperson, Dr. Dlomo, the question that was also raised of how we can mitigate the medical legal claims from the pharmacy space. I think the digitization and the prudence of the pharmacy sector up to so far is a clear example that medical legal claims being unavoidable at the current juncture. You will note that in pharmacy, they are a little lower than in other professionals. And in so saying, it's not to say we are any better, but I think there is something that we have done well with regards to ensuring that records are kept and digitally and otherwise. And I think we can contribute to the NHI in terms of the current softwares that we deploy with regards to our dispensing and our monitoring of our patients. That is just to add and to contribute. And I just want to wrap up before this last 30 seconds remaining, is to say we will also are happy to share some of the papers that Dr. Sham referred to with regards to the lay ownership benefit versus damage, having passed that law in 2004. I believe that we will be the committee will be happy to see that paper and interrogate it and see the evidence with regards to the lay ownership and its impact in the current market. Let me pause there, Chairperson. Thank you very much for the opportunity this afternoon. And honorable members, we thank you for the questions. If it's allowed, we may want to forward answers to some of the questions that may have not been answered because of time, if you allow, Chairperson. Thank you.
Thank you very much. We will ask you to send those questions that you may not have actually answered here in the platform. It will help us because we are still engaged with the whole process of NHI. Thank you for your contributions. We'll keep on interacting with you whenever we need, but do send those. I may not allow you to have your closing remarks because of the time pressure, but we really enjoyed your presentation and interaction. Honorable members, we will take a lunch break. We'll come back at 14:35, so 25 to 3. We just add 5 minutes of the time that was given. Thank you very much. Hope you enjoy your lunch.
Thank you, Chairperson.
Oh, well.
Thank you, Chair. Bye.
All right. Okay, bye.
Thank you. Bye-bye.